I have a recording of the fest too.
Yeah, the first case.
The first case, which I haven't given to you yet.
Yeah, so just share me a link when you're done with all of this.
Yep.
Okay.
It's good to have a coffee anyway.
Mm.
It is.
That guy for the second case, though, went well. Clinically. You know, it's complicated surgery. He got his smell back at the chest.
Wow.
He's pretty happy.
Wow.
Hard to be a pastry chef without his smell.
Hello, Professor Carney.
My friend Andy Kristen still raves about the miraculous cure you gave him in your rooms.
Oh, yeah. He's a fortunate man. He just had something that I could do something for.
he was amazed.
Not everyone is like that.
Okay.
check 佢打翻個。
好冇錯。
咦？你哋而家用緊一部電腦用緊？
一部電腦啊。
OK。但係你哋而家喺一個人嘅嗰部電腦。
我有，但係用 OK 其實一部電腦都咁你係想要你係想用兩部電腦入好？
我唔緊要，你嗰兩部可以一齊做，大家做，每日都 OK。我會暫時 spotlight 我如果佢哋講我哋 spotlight，如果你發現我電腦做咩先？我一陣先至再入去啦 OK。咁係先。
Remember we went and saw
Hello, Professor Carney.
Prof Yep.
We're only showing the scan to them at the moment.
Okay.
Anyway, Isabel's very keen. She wants to have something to show by February. That's what she's told Joanne. So we are moving forward. That's
It's exciting.
yeah, it's okay, so we're not reaching. Are the endocam ready?
Yeah, it's all on the truck. Just we'll mic him up at say a few minutes before 12.
Tell you what, that's only just long enough. You guys, once that's in your pocket, it's kind of only just, you know.
Puppy shape.
Yeah. Yeah, I know, but I'm just saying, we're going to keep it outside or under the shirt?
Under the shirt.
Yeah.
After a couple of sector. May or may not have one.
I've got to get in touch with Paul Brunton again. He's keen for a coffee again sometime.
Yeah.
There was an exhibition on at the library last month. Nobody got in touch with me about early maps. Yeah, but I don't know how.
Sprayers in there. There's a sprayer.
Oh, you've got a kerosene.
There's a couple of nice kerosens in there.
Thank you. Thought I'd have to use this ridiculous one over here.
There's a sprayer. That big, is that it?
Yeah, no, I was actually looking for.
Sorry, put the camera on.
There's a little ball probe there.
You use
We'll see.
this pretty
First
small
kicks
though,
off.
at least.
Otherwise he might actually speak
There's a
to
little
you.
ball
Yeah.
probe there too if you want.
I'm good with that though. That's great, thanks.
So So we'll have to get the mic on soon because you're 5 minutes or something. Yeah.
But no one wants to see.
Another bit for you, with the neck.
Yeah, what about some of
I'll
it
see
there?
that way a bit.
Yeah, so almost in line with the, if you can put it in line with the two yellow things, like if that forms a straight line from me.
Limbs.
Oh,
He's
all good.
the
Keep going.
manager.
Okay, yeah.
Yeah, perfect.
Like that.
Love it,
Is
yeah.
that back along with you?
Yeah, that's good. And even if you can move the screen a little forward, that's good.
Bring it forward to you. Limit.
Okay, love it. Perfect. Now let's get a couple of things ready and do all this.
You want to school? You want, how do you have to stand?
I'm good, thank you.
Yeah.
See, look at all the effort to make it all go.
Make up for the last one.
Yeah. Suddenly clean.
Isabel.
5 minutes of prep, mate. What?
I'll just see if there is some.
Because she's told me a few times.
I mean, I'll just see if there's. Is there any anti-fog down there?
There's not one.
I also take like the phone ones around.
She's starting out on it.
25%,
I'm worried that it's
75% off.
Yeah.
Bit of
Her job, 75%. She needs to know.
Just grab one of these and a bit of detergent.
I was going to say, you know, you only paid half price for it.
Listen.
And looks very good. Okay.
When you're ready, Richard, we'll mic you up.
Mic me up.
Yep. Okay, now, can we put this under your shirt so we don't have this thing dragging through? So if you can help there a bit. Whichever way, probably from down there. Fine. Down a little bit lower, but just there, yeah, just underneath the button, just there, that's a good spot. Perfect, and that side pocket, wherever.
It's on now. Yep.
It's on? Yeah.
Yep. It's good.
We haven't unmuted you yet.
There. That's fine.
We can mute you there. Okay, sorry.
Hello, morning.
Oh yeah.
Because it's
Are you all ready?
possibly on your collar. Yeah, just
You can unmute me if you like.
Yeah, you're unmuted.
How's that?
Hi, Tim.
You want to put your camera on?
Okay.
You can unmute me if you like.
You're unmuted. You're
Oh, we
live.
can see your screen. We can see Harvey.
Hey, how's it going?
Hi, morning.
Talk to him, Matthew.
I'm very happy. So I will let Charles to start the videos and let the participants get in right now. Is okay?
Yeah, sure.
Okay. Yeah. So Charles, can you please start the webinar and we can waiting the participants to get in.
Hi Richard, how are you? Good morning.
Hey, who's that?
David.
David, how's it going, David?
Good, good, thanks.
Let me...
Where are you at? This is at St. Vincent's.
Recording in progress.
It is...
We are now broadcast.
We're at the lab at St. Vincent's.
Yeah, I see the...
think I'm good, Jeff. Yep. I think I'm good. Can you hear me still, David?
Yes, Richard, I can hear you through the music of the video.
Yeah, no problems. Fantastic. Well, you should take us through, like I'll just start talking, but and take us through like various things, but I really need you guys to be interactive, you know, here. I think that's going to be the main thing.
Sorry, I just got to...
Am I unmuted?
I can't
Yeah.
hear you. Yeah.
David can't hear me. Can Simon hear me?
Yeah, it's a bit better now.
I think
it was a bit weak before.
Okay. All right then. Do you want to put this down lower on here? Yeah, I'll let you do it. Yeah, better you do it now. I've got my gloves on.
Rubbing your neck, is it a...
Or just, I just think it may be better down here somewhere.
Just, okay. What about that?
Yeah. How's that, Simon, for volume? Still quiet, is it? Yeah, it's a bit hard with all the music. We can't really do. What we'll do is, why don't we do a quick sound check once the music and intro stops, and then we'll just make sure that everyone's happy. It's all right. We'll just do it. I just want to make sure that we're not fiddling with. I can hear everyone. Oh my gosh. Yeah. Check, check, check. I think we got wood. Yep. I think.
Great. Well, good morning, good afternoon, good evening, depending on whereabouts in the world you are. So my name is Simon Carney, and I'm one of the APOST board members, and it gives me a great amount of pleasure to welcome you all to the APOST Advanced Sinus Surgery Cadaveric Demonstration, which is being done by Professor Richard Harvey in Sydney. So first of all, I'd really like to thank Richard for giving up his time on a Saturday. It takes a massive amount of effort to prepare the lab. We'll get a chance to thank Richard again later, but really do appreciate the amount of effort that's gone in. In particular, I'd like to thank the sponsors of this meeting. Olympus, in particular, put up the vast amount of money to sponsor this event, and Medtronic as well. And we do appreciate their ongoing support. The APOST team out of Hong Kong have put in a massive amount of effort as well to get this going, and we've got over 1,000 people registered today, which is a fantastic achievement. So Charlotte's just going to put up some welcome slides. And the important thing today is to make this interactive, and I'll really encourage you to use the chat function, the Q&A function, and the moderators will try and get all your questions answered. So APOST is now 5 years old. COVID's really interrupted things a bit, but we started it in 2016 with the aim of really promoting training and education in the Asia Pacific region in all the different specialties of ENT. And we've worked closely with a lot of the local ENT groups and run joint courses in several different countries around the world. Next slide, thanks, Charlotte. So we've had hands-on dissection courses in several countries around the Asia Pacific region. We've had dissection demos in both rhinology and otology, and we've had live surgery demonstrations. We've had lecture formats, and in particular now we're doing a lot more online training. A lot of the videos that are done on the courses are now online with e-learning platforms. So I encourage you to go back and look at some of the presentations in the previous courses. There's an increasing amount of content being done. So we've done all kinds of board. It's an increasing number as we grow in size and status. Leading right from the word go. Michael Tong is the chairman out of Hong Kong, and we do appreciate all the other board members who've hosted courses and put in a massive amount of time free of charge to help APOST grow and develop. So next slide, thanks. So in 2022, we're hoping to actually run some live cadaveric training courses with people in the labs again. And in March, we've got a dual location, one with cadavers in Hong Kong and Bangkok for the Hong Kong and Thai students. And there's going to be 4 of us, faculty, doing mentoring, so that'll be quite an interesting experience, teaching people from Australia who are dissecting on a cadaver in Hong Kong and Bangkok. So please feel free to register for one of these courses if you're in one of those 2 locations, and I presume there'll be an online component to that as well. Next slide, please. So this is the 2 centres we've just discussed in Prince of Wales and Chulalongkorn. Next slide, thanks. And this is how we're going to do it. So the video cameras linked to the cadavers in Hong Kong and Thailand, and then the trainers will be viewing those cadavers and talking to the dissectors and running them through it. Next slide, thanks. So 16 trainees will be attending. I'm going to be doing Hong Kong, Richard's going to be doing Thailand, along with the rest of the faculty. Next slide, please. We then got narrowband imaging and laryngology, which is going to be run by Jason Chan and John Lee out of Hong Kong. And again, that'll be telemonitoring. Next slide, please. And this is today. So we've got myself and David. I don't know if Joe has managed to join us yet. Certainly from Australia earlier on, we were having some problems with Zoom. But Joe Rinner, who's from Monash in Australia, will be also joining us as one of the moderators. And do thank David as well for giving up his time from Singapore. So Richard's going to cover several things, not necessarily in this order. So we're going to be doing septal surgery. He's not put turbinates up there, but I'm sure he'll be doing a bit of turbinate surgery as well. Anterior endoscopic sinus surgery. We'll take you through sphenopalatine arteries. We'll talk about Vidian neurectomies, posterior nasal nerve sections, if you want to talk about that. Then extending beyond that into the sphenoid, posterior ethmoids, and of course the frontals. And then Richard's unique approach, Caroline's window technique, which is certainly something I have embraced and brought into my practice. We'll look at the prelacrimal approach to the maxilla, which, if you've not seen that before, is another thing you may not have learned, but was really a fantastic way of getting to that anterior maxillary wall. We'll then do a medial maxillectomy, do the draft 3 frontal drill out, the outside in technique, and then an intertemporal fossa dissection. And then we'll just see how we go time-wise. Next slide, please. So Richard needs no introduction. He's an APOST board member and really has probably done more of the APOST science courses than anyone else. He is really a world leader in advancing rhinology and has been on all the APOST documents. He runs his own sinus course in Sydney on a regular basis and has basically been invited faculty at probably every single sinus course around the world. He's probably missing travelling quite a bit, because in the past I think he would be doing at least 10 courses a year internationally. He's got a massive research programme in Sydney and is sort of universally acclaimed as a key opinion leader. So Richard, we're really grateful to you for dissecting today. And again, thank you for your time. And the next slide, or is that it? Is that the last slide, Bonnie? Me? No, you don't want to have me up there. So next slide. Who else have we got? We've got Joe, who I've introduced from Monash. Next slide. And then David, who is the sort of up-and-coming rhinology king in Singapore, and helps run the Singapore rhinology analogy course, which is his baby. And if none of you have ever been there before, I'd certainly recommend you either attending the course online or attending in person over the next few years. It is a fantastic course. So next slide. And yes, and just keep in touch online, Facebook, and as we said before, use the e-learning platform and watch the videos, because there's a massive amount there. And we welcome you to the APOST family, and we hope that many people who come through APOST as trainees will go on in the future to be APOST trainers, and just keep this snowball rolling and keep up the good work that has been started by Michael and his team in Hong Kong. Thank you very much. Next slide, or is that it? Right. So I'd like to, first of all, I'll just hand over to Richard for a brief discussion of what he's going to do today. And I know we've got some radiology of the cadaver, which Richard might want to run through before we start. So welcome, Richard, and over to you.
Hi, thanks very much, Simon. I think you thanked everyone, including all our sponsors that have agreed to help us. But I have to give a really big shout out to Steen and his IT crew and audiovisual crew here. They've done an amazing job at making sure this webinar is nice and smooth. And then we've got Melinda as well, who's not with us today, but and Kate, who are part of our lab crew here, who've set everything up and got everything ready. So I just had to walk in with coffee this morning to make it happen. Now let's go to the radiology view. We'll get straight into it. So here is the images here, and I might, is it possible that we could just drag the gallery view of people maybe to the other side? Yeah, that's fine, perfect. So when we're looking at the coronal image here, I'm just going to scroll forward here. Obviously this is a fresh frozen cadaver head. You can see that the person's got good pneumatization, but let's go from the very beginning here. The first thing I think you should always note when you're doing a sinus procedure on someone is are you going to be challenged by the position of the septum? And you can see that this high septal deviation here is really going to be problematic for us. So Simon, we're going to have to do some sort of quick endoscopic septoplasty, and I'll take people through my principles there. But as you come forward, something I just want to point out, look here how we've lost the bony septum, but I really want people to appreciate where we are. So my practice, I do a lot of nasal reconstruction and rhinoplasty work as well. And one thing I think is very common is to see people do endoscopic or endonasal septal surgery, and they really are very fearful of the keystone area. And they end up leaving themselves short at correcting the upper deviation. If you have a look here, we are into the cartilaginous septum right now, but look where we are on a sagittal view. We are still underneath the nasal bones, level with the frontal sinus. And so, you know, I'm going to come back to that when we actually do the septoplasty. You've got to make sure that you take the cartilage and septal bony deviation at that point really high, otherwise it'll always be a problem for you. And it's not a part of the keystone area. The keystone area is much more anterior or caudal than that. Now, as we come down here, you can see that obviously it's affected by ice, but we've got a bit of a septal deviation, Simon and David. We're going to have to do something now. It's got a nice frontal pneumatization. You can see that there, here on the left-hand side, there's some sort of frontal ethmoid cells. I must admit, I don't really go into breaking them all up, extensively. I don't really see that as being an enormous amount of help. But on the side view here, you can see that's probably, at least that's a Agonasi cell or true frontal cell. I don't think it's a ethmoid cell coming up or coming from posterior. Here's the orbits. Let's go posterior now. I'm looking now for the antrostomy artery canal. There it is there, somewhere in that zone. Would you agree, guys? There it is. That's pretty close. Obviously, you can see it in most people here. You can see this little canal, so-called Kennedy's nipple. It's often seen at the junction between the superior oblique and the medial rectus as well, where they come together. That's the other way of finding it. As you come down, then, we often go looking for the posterior one. So the posterior one is probably just, there it is there. So that's the posterior ethmoid. That's Schloss's nipple, the smaller one. And so that's a posterior ethmoid entry point. Oh, there it gets even a bit more prominent here on this next slice back. Now, as a sinus surgeon, I don't really go naming all the cells, but what I do want to see is what's happening with the skull base. You can see it's a little bit asymmetric. There may actually be a little bit of a fracture through it. I might just move that out of the way. You can see there's a bit of asymmetry to the skull base. If you said to me, is that a low skull base? Well, generally any skull base that is below the junction of the upper 1/3 and bottom 2/3. So if I had to put my guideline, that's about the junction of the upper third and lower 2/3. You can see probably the right-hand side you'd say would be okay. Still, you wouldn't really call it low, but the left-hand side is definitely low in my opinion, and a little asymmetric. And then I go looking at the medial orbital wall. I just want to make sure that the medial orbital wall isn't dehiscent and there's orbital contents sitting in the ethmoid cavity. And really, that's it. Knowing where the antrostomy artery canal is, seeing whether or not the skull base contains dehiscence and there's cranial contents sitting in your ethmoid, and making sure it's not doing something unusual like dipping down where it shouldn't be. And likewise with the orbit, making sure the orbit's not sitting in the ethmoid cavity. These are really the only absolute things I think you need to look at. So, and you can see, only other note I would make here, you have to forgive all the ice, of course, in the specimen. I look at this head, Simon, and I think it's one of those heads where the ethmoid's a pretty narrow ethmoid, don't you think? Look at this. 7-8 millimeters. I think that's something that a lot of people often don't recognize, that sometimes you've got a narrow ethmoid, and we'll actually see how that plays out for us down the track. Good frontal pneumatization. Let's go back. I can't really tell whether there's concha pillosa or anything. Here's the sphenoid. There might be a little fracture in the roof of the sphenoid. We'll see what's happening there. There's obviously some sort of a noddy cell here or partition, and pretty good sphenoid development. And here at least on the right-hand side, there's that lateral recess development splitting your foramen rotundum and Vidian canal, that VR line that Joanne Sethi always talks about. So let's get, on that note, let's go to the specimen and let's get started because we've got a fair bit of dissecting to do. Let's pull it up. So have we got we've got the endoscope view now going? Yeah, fantastic. So listen, I've spared everyone the pain of just finding the right plane here. But I'm going to take you through. Yeah.
Can I just interrupt just for a second?
Yeah.
If you were saying that your view is quite small on their screen.
Yeah. Okay. So
Charlotte, I don't know whether that can be corrected from your end.
That might have been a problem from the perspective of looking at that 3D. Yeah. Well, what we'll do is we'll go to the endoscope view. We might, if we come back to the CT scans, then Simon, we'll just look at one set only, maybe not the 3D.
If someone on the one of the participants can just see if that's improved things a bit. We've got Dave Chin as the main screen now.
Yeah, let's just make sure that we.
Use the main screen.
You got to pin the endoscope view as the screen, guys. Let's make sure that we're not getting the voice pushing the screen around on people's computers to different participants. Okay, So here we go now. Is that better, Simon? Yep.
Sorry, it looks good for me, but it wasn't me that had the problem.
Yeah, no problems, no problems. I think we've spotlighted it now, and we should be good. Okay, and just make sure that you got participants muted and everything. So here we go, Simon. But you guys pipe up. So I've made a small hemitransfixion, and I've gotten down here. I'm not even convinced I'm absolutely in the right layer actually yet. Always hard a little bit in the cadaver. Yeah, I probably am. Okay, so when you're doing an endoscopic septal surgery, I mean, this is not advanced vest, but just the concepts here is really that people try to push the mucosa. See, I'm pushing the mucosa. Really, I spent a lot of my time with trainees saying, look, don't push the tissues. Dissect them by forcing the instrument between the bone and the soft tissues. So you can see now, I've stopped pushing and just forcing myself onto the bone. And I think that's one of the sort of lost arts, don't you think, Simon, that people often don't pick up on training them, unless someone's pointed it out to them. So you can see how we've come to the sphenoid rostrum, and I might just tighten up my view here. There you go.
We've still got a problem with the pinning of the video, apparently. So apparently you need to pin, Charlotte, other guys in Hong Kong, you need to pin.
Or spotlight my view, or pin Richard. You got a spotlight, really.
It is spotlight.
Yeah, but mate, is it going through someone else, or is it?
We're doing it, we're not doing it.
Yeah, right, okay. Okay, well, I'm gonna keep going, and hopefully.
Yeah, thanks, Rich.
I'm gonna keep going.
The endoscope certainly made teaching septal surgery a lot better.
Yeah, exactly. Don't you think? I mean, I didn't have it when I was a trainee, and I had to be described what was happening. But you can see here how we can really get onto that layer, and that's really what helps us here. Now, you have a couple of options, right? So when you come down to a thin area here, you can try to develop the plane now, but the other option is simply to, let's find out where our bone is. There's our bone up there. There's bone, bone, bone. There's the cartilage, so you know where we are, and you can actually see where it's deviating. Sort of deviating somewhere here, so I'm going to do just a simple Cottle-style septoplasty, just make an L release, because we're just doing it for access here. So I like to score it, and you can see we're just in front of the bony cartilaginous junction. And once I've scored it, I then use the blunt end, and they're going to come in, and once again, on the cadaver, we'll just make sure we're in the right plane before we go on. Actually, in real life, it splits very, very easily. And then I try very hard then, if I need to move it out of the way to get in. There you go. And there's my camera down the other side. Let's split this up. Once again, not pushing the soft tissues, but literally forcing my dissector on the bone. This is the one thing that I would say if you want to become a slick dissector is just always think about forcing yourself between the soft tissues and the hard bone. That's how we end up making things move forward. You can see I've got a bit of ice there still. Now, you want to find the sphenoid rostrum doing a septoplasty, and then you want to see the nasal floor. Not only is it good for orientation, but it's really then, you really then do raise properly, there it is, your two tunnels. Do you still teach the tunnels, David, in Singapore? Inferior and superior tunnel above and below the crest, is that still a concept?
Yeah, we talked about it because when dissecting the pericondyum and periosteum, there will always be that layer where the trainees will find it hard to
transition
come across.
Yeah. So you can see here how we're right onto the floor, right? That's so important because getting that laxity just makes a big difference too in terms of making sure you're not going to tear anything. And the nice thing is that here on this side now we've got lovely mucosal layer. So it doesn't matter if I get a tiny little tear on the other side. And in fact, you want a little bit of a drainage hole. But we haven't got a tear yet, and I'm going to try not to, because I'm going to talk to you about, oh, there you go, just as I said that. So a couple of techniques. He said to me, how do you develop the plane on the other side? So one option is you take the cartilage off the crest. I'll just move it out of the way for a moment. And then once you see the bone, it just gives you another opportunity to dissect it. And so you can come in. Obviously, working from back to front is always the best, but then if you can't do that, just transition from the posterior bone, you can go here. Now, one of the nice things about the endoscope, of course, Simon, is that, you know, getting this view right now was near impossible when you came to doing it as a headlight procedure, don't you think? You never would have seen that little pocket.
Richard, do you use a hockey stick if you come from back to front?
I don't actually. I just use the Freer, or I use a Cottle dissector because Cottle's a little bit narrower. Now you can see I've got a little bit of this here, so we're going to take that off. We'll get rid of this cartilage, and we'll take a little bit of the bone off so you can actually see what's next. Now, so if you have a spur, don't be afraid of dissecting it in components so you can see. So here's our floor now, and once again that view that you just very hard with Achilles and open. You know, I always found that tricky, and it just means I can really mobilize the whole mucosa off that spur before I take it out, and therefore, you know, I think I've got a pretty limited tear considering the degree of septal spurness happening there. Now, all of this, of course, we're well back. We're only just on the junction here, right, of the bone and cartilaginous nose, or septum, I should say. So I'll just take out the rest of that spur. That can all obviously go very quickly. You can see...
One of the big controversial things is how much do you take out and how much do you leave in and put back in again?
Well, you know, it's got nothing to do with the bony septum. You can always take out pretty much all of the bony septum if you wanted to, you know. But as you get forward, you do have to make sure that you leave support for the nose. You know, you got to have it. You got to have at least a big. You got to have a dorsal strut and a caudal strut. But you know.
Do you worry about tapping septum if you take too much out?
Yeah, that's one of the reasons why I will put stuff back if you do quite a large resection where around the nasal valve area, you've taken a really big L strut, and so you really just have your dorsal and caudal edge. In that setting, when there's that's when I put some cartilage back. And I do it for that very reason that Simon just mentioned. At the level of the nasal valve, you do get like a Bernoulli effect. And you will see some people who've had the old sort of submucosal resection of the dorsum. They get like a vibrating sensation. But it happens at that level, Simon. I think the very posterior nose is probably protected from that. It's where the airflow occurs and you get the sucking effect around the nasal valve. Now, once you get the big area here, I'm not a big fan of people who torque it. So we're going to come in here now with the big heavy Mayo scissors and we just cut it. And so by cutting it like that, it really, you're not going to twist the perpendicular plate. You know, it just separates it. And you should take out that bit of bone where it goes thick. So there's the cartilage bony junction, and then it becomes the thin perpendicular plate. And that might be it, but you have to get this area, Simon, here, in order to have a view that's not obstructed when it comes to FES surgery, because that area is just here. And I think that's one of the biggest areas, Simon, that people leave. You know, they do their whole septoplasty and then they look up and they've got this high bend here. Can you see how...
Stops you approaching that axilla and cartilage
window. Exactly. DCR surgery, everything. And you see how I've got like now almost a straight view into the olfactory cleft. That's sort of what you want, and we'll have a look on the other side. I mean, I know sometimes you might have a little bit of what we call swell body and things like that in the way. And you can see on this side, we're almost there, but not quite. You see, I've got like a little bit of a fullness here and a little bit of a high deviation here. So I've still got a little bit of a high deviation. So I probably would come back in here and I'll actually take a little bit more out.
Have you seen many cases of CSF leaks where people have twisted the septum high posteriorly?
Not really. I mean, I think because the septum closes, we don't see that very often. But I do. But
a few case reports in the literature.
There's a few in the literature. What I think is more common is smell loss. So I think that's where a few people have had a septoplasty and then just mysteriously lost their smell. I actually think what's happened. See that? See just removing that last little bit of bone, how much nicer that's made that, Simon?
Yep.
Do you agree? Yeah. So just so important to sort of get that bit right. Now, what side should we do? Should we do this side? Should we do the other side? What do you think? We'll do this side, right?
What would you I think it's important, Rich, to say what would you normally do when you've got a septal deviation? Do you do the concavity or the convex? I
actually inject the nose, put patties in, then I'll do the septal surgery while that's all waiting. So just from a practicality, I don't necessarily do, part of the surgery first because the septum's there. I actually like to use that time while I'm doing the septum to really prepare the whole nose and get it all, sort of nice and decongested.
Yeah. Richard, Joe's online now. I'm going to hand over to Joe to lead. Do you want to talk about what your preparation usually is? Yeah. So my preparation is that I normally put some patties in with 1 in 2,000 adrenaline and 1% Narrapin, and then I'll inject after I get everything set up on the table. And I just got a bit of echo, guys. Can we just double check the echo? Thanks. And then I'll usually inject with a little bit of. Yeah. Okay. Just want to mute if someone's maybe. Thanks so much. Oh yeah, perfect. Thanks so much. So then I'll normally inject with 1% ropivacaine, with about a 1 in 100,000 adrenaline dose and a small amount of tranexamic acid. I usually use 100 milligrams for a 10 ml syringe, and that's my standard injection. Now let's go to here. So one of the first things, and I'm intentionally picking this side that has the middle turbinate, slightly squashed, right? You can sort of see the olfactory cleft, which you don't really want to see. But you can see how the whole sagittal part of the middle turbinate is sitting in the wrong position to do surgery. So instead of just cracking it across, what we do is we come in and we do what's called the Peter Wang sort of basal lamella relaxing incision. And so you've really got to come up high up here, right? And you see where we are. We're nowhere near going into the brain or anything else. And then what we do is we just gently push to the point where you can hear it fracture. I can actually hear it fracture. See just there? That's all you need to do, though. You don't need to sort of push the freer all the way through, but you've got to go from the top, Simon and David, all the way down. And Joe, in my opinion, I think I see people attempt that, and they do some little section here. It's actually got to be right up here. And only if you do all of that will it sit nicely like that, And so that's such an important maneuver, and often missed, I think, when it comes to setting yourself up for success here. Okay, let's.
Just to clarify, Richard, you're doing your releasing incision on the middle turbinate so that you don't crack it and crack the skull base. No, just for access. Just moving the middle turbinate, you're not going to crack the skull base. It's purely for access, and I think if people grab their freer like this and just push it over, they just create a whole lot of bleeding here, and it's sort of in their field. But if you do it here, you end up releasing it where you're going to go through the basal lamella to do a full house fess, and it just allows the middle turbinate then to sit in a really nice position. Just crack. You can do this. You shouldn't have any fear as a doctor you're going to create a skull base leak by doing that to us. The
other thing, Richard, I think this is quite nicely demonstrated on this side with that slight septal deviation, that the middle turbinate can now sit sort of behind that slight deviation, and you don't lose any space.
Yeah.
When you approach the ethmoid.
Exactly. Now the next thing you want to do is you want to do an uncinectomy just to see the antrostomy, just to see the maxillary sinus, because the first thing we need to find is the roof of the maxillary sinus or the orbital floor. So I do like to come in with a backbiter. Now look where I'm engaging. Look relative to the middle turbinate. I am at the junction of the upper 4/5 and the lower 1/5, right? And you can see my instruments in that. It's behind the uncinate now. I'm going to bite it.
I'm going to come forward, and you can see that's the fontanelle. See how there's no more soft tissue. The soft tissue ends in a tiny little groove that you can see about there. I hope that comes up. So you really can't bite more than that, right? That's your limit of your biting. Then what I do like to do, and pretty consistent with all my surgery then, is after I've made an opening, preferably through the natural os, although you don't have to do it, as long as the natural os is connected at the end, I then put the probe in. Now, one of the errors of people putting the probe to stretch the os here is they enter back here. So if you enter back here, you often miss the os and you'll strip the roof. So it's really important to come right forward and see if you can enter as far forward as you can and then stretch back. And so you can see me stretch back now. Now I'm staying high, so the stretch is high, and once again, it's not down. If you push down as you stretch, you'll strip the roof. That's a real rookie error. And then you just create a false passage for yourself. Then I like to do everything with straight instruments. So straight through cutting instruments is really my preferred way. So then I'll get the straight through cuts and continue along the roof. Now you can see I'm coming up to the end of the posterior fontanelle, so then I'll bite down. You don't want to bite so far back you get into the bone and the vessels. And you go down. And in essence here, you're making what we call a lazy L. And I think one more bite. There you go. So, can you see what I mean by an L? It's this shape and then down. Can everyone see that? Yeah, so let's then get...
Richard, there's a few questions coming in.
Yeah.
We've moved on to the next part of the section. We'll deal with the questions at the end. Just for people thinking I'm ignoring the Q&As, we'll deal with septoplasty questions at the end, if that's all right.
Yeah, ask the questions as we're doing that actual procedure. You know, so therefore I've cut down and then I've come along the upper border of the inferior turbinate, and it's curves upwards, right? Another sort of rookie error I think people make is they bite straight forward and they end up getting into the inferior meatus. Now the next one here is I always do the lower uncinate first. I've seen this technique where some people go and do the up uncinate after they make that cut. Well, to me, I think that really struggles. It means that you're just making things bleed down into your field. So I always like to do the bottom first. And then I'll pull this forward, but you don't always have to pull it forward. If it doesn't come forward, you're only pulling it forward to get into a good position to bite. So it doesn't matter. If it doesn't come forward, then we'll just use the keratins to remove it. Yeah, Joe.
I was only going to ask, obviously this is a retrograde uncinectomy. Do you ever do an antegrade one?
I will in a completely everted uncinate. So that's probably the one time that I prefer to do it. You know, when you get those sort of uncinates that's completely pushed out and everted. Sometimes
it's much easier than trying to get a backbiter behind it.
Exactly, the backbiter is no longer in the favourable plane, and I think sometimes you can actually see the fontanelle. Now, one of the things you'll see me have done there is I've done that technique which we call the crunch and gobble. And I might just get my camera view a little bit sharper. I'm going to try to get a consistent...
So Richard, while you're doing that, we had a question about how you avoid injury to the orbit and also to the lacrimal duct when doing your uncinectomy.
Oh, yeah, sure. You know, so let me get this off and I'll talk about it. So first of all, is you've got to find the groove between the uncinate and the orbit, right? If you can't, I mean, the backbiter is a very safe technique to do that. But say you get one of those uncinates which is completely plastered. You know, Joe, we do get those occasionally. What I'll do then, one of the techniques you can do, or that silent sinus or sucked in sinus, is you come back here into this posterior fontanelle and push in here. And I've got someone who's just got their mic on, is getting a lot of echo. Maybe they can go to headphones or something else, just whoever's got their mic on now. Yeah, Joe, if you can. And then so as we push in here, we pop into the posterior fontanelle, and then that allows you to come forward and come up to your natural os. one of the errors I think people do is that they get fixated on always finding the os, and they can't almost do their surgery without working from the os backwards. And I think that's a bit of a flaw. You know, I think we've got to be, you know, got to keep your mind open to, you know, getting in there a different way if it's really tight and plastered on the orbit. You just poke open the posterior fontanelle and just come forward. So that'd be my trick, you know, to get in there. Now the next one, does that answer your question?
Yeah, that does. The next one was about injuring the nasolacrimal system.
Oh yeah, just don't bite forward. See where the fontanelle is. Now the next thing I do is I'm going to pop this open. Now the next one here is, once you get the bulla face open, I usually like to use an upbite, maybe 1 or 2 upbites, and then I'll use my straight bites and I'll take away the floor. Can you see I'm taking away the floor? And then I'll take away the medial wall of the bulla. Can you see that? And I'm trying to keep everything pretty tight, right? Not too, you know, I'm trying to get what's called a mucosal sandwich every time I bite. Can you see that? And I just turn it into like a mucosal soup. Then after taking the medial wall off, the front wall off, I then want to take this rest of the anterior wall out so I can see the orbit. And I really want to see this corner here. This is the most important bit. Because if you said to me, how do I find where everything is when there's disease, right? You're not allowed to sort of cheat and just look, right? You've got to know. And one of the things you can do here as a surgeon is really define this transition. And it's finding the orbital floor where it transitions to the medial orbital wall. Now you might say, okay, in a cadaver you can see it, but I'm actually operating like I do in a real case. You know, so I don't care what that would be, polyps, tumor. What I would do here is and I'll just check I've got a little tiny halocell or something happening there. We'll get rid of that here in a second. But you can see the orbital roof, right? I'd bet my mum's life on that. That's the, the sinus roof or the orbital floor. Can you see that? And as you come across, the floor ends here. You can see there's no more floor. The floor is no longer here. So that means that this has to be the orbit. And even though, yes, maybe you can make it out on a cadaver, if you just look for that and then where it transitions, that makes that the orbit. There's nothing else it can be. And so that's what I encourage people to see, this corner here. As long as you can see this, then you know where you are. The other little subtle things here is that there's mass movement, what we call Cohen sign. When you touch it, it all moves as one. You know, that's a great sign that you're on the medial orbital wall. Now let's go through and transition to the posterior ethmoid. Now one thing that's true here, and is very important for those of you who are new to FES, is that now you've got your goalpost, you've got your medial orbital wall here, you've got your middle turbinate here. You want to be operating in this zone, between this space. And at this level, at the orbital floor, you know that as long as you're at or below this level, going through this cavity, you will be safe. So, it's not about some location that I just think looks good. It is absolutely related to the orbital floor, and I'm going to go through the basal lamella here. It is not something that there is no air cell track for you to follow. This has to be a surgical opening, and there it is there. I've just made it. Once you've made that surgical opening through the coronal part of the middle turbinate, you can bite through it. Then I've taken the front wall off. You can see that. Now, can you see here how this medial maxillary wall comes up, guys? And about this point here, you get almost like a Y. A Y here and a Y going across. Can you see that? Does that make sense?
It's very clear,
Yeah. So what you do is you've got to remove the bit that overhangs the maxillary sinus, because behind it is your posterior ethmoid. And that'd be my other number one thing I think I see in people who get themselves into trouble. What they do is they don't really remove this. And what happens is they end up creating a tunnel into the maxillary sinus and a little tunnel down there. So all of that goes, which is often referred to as the orbitoethmoid plate, will go. Now, if you want to do it all in one go, the next thing then is to take your middle turbinate window out a little bit so that you're expanding this opening into the superior meatus. And I think about there. So, when you now pick up your shaver, and we do a bit of crunch and gobble, you can see I could push it even more, but I didn't want to strip. There's the window of my basal lamella. Can you see that little loose bit of mucosa? Now, that's still, there you go, that's what I want to see. So this now, when you look at it here, is all the anatomy you need to see. The roof floor of the orbit, or sphenoid sinus roof, you've made an opening into the posterior ethmoid. You can see the superior meatus now because this is your superior turbinate. And these are your posterior ethmoid cells. Now my preference, this often in many cases this is full of scar tissue and tumour and polyps. I don't go opening all of that now because you still don't know exactly where the skull base is. So what we're going to do is I'm going to give myself a little bit more suction here by clamping my... I don't have the fabulous sort of operative suckers down here in the lab. So there is where we're going to find. Now, this is obviously, I'm practicing what is referred to as a trans-ethmoid approach to the sphenoid, right? I do transnasal sphenoidotomies for things like pituitary surgery, but almost everyone gets this approach when we're doing sinus surgery. So I find that level. I'm working between my lateral and medial boundary. This is also my medial boundary here. And I'm going to go in and find the opening to the sphenoid. And it's about here. But I know my orbital floor is here, so I'm just not going to go any higher. And you know what? I don't care right now whether I'm in the actual true os or not. What I am is below the orbital floor. And I'm going to stretch that down. You can see how I'm stretching the posterior, or the fontanelle of the sphenoid, as it's often referred to. And then I'm going to get my kerrison. I'm going to engage that spot, and I'm going to bite out laterally. Now, the days of biting down in the hard sphenoid rostrum are really no longer apply. I don't think anyone really practices like that anymore. We bite out laterally. That's where all the anatomy is. You know that the floor of the orbit is a good guide to the skull base. You're always safe there. And it's at or about, that level, so you don't have to stay absolutely perfectly below it. And this is the medial orbital wall out here, so you can bite at least out to here with your shaver, or your kerrison, I say, before you put a shaver in. So I do at least sort of 8 or 10 bites using those landmarks, and then I get my shaver in. And we'll remove that posterior ethmoid sphenoid junction point.
Richard, are you worried about the septal branch of the SPA?
Oh no, it often goes when I'm doing... First of all, there's multiple branches there, and I almost think your sphenoidotomy is not complete unless you picked up one of them, Simon. So, normally you should. If I don't actually see some sort of bleeding vessel down here, then I don't think I've done it low enough. And I'll talk about what is low enough in here in a moment.
And would you use a suction bipolar, or are you happy with a suction monopolar?
No, I use a bipolar forceps actually in most sinus cases. I use the needle point diathermy, which is monopolar, to do most marking out of flaps and various things. But when it comes to the actual sealing up of bleeding points, I use just a Hardy's bayoneted bipolar forceps. There's been lots of things developed over the years. I'm always happy to be introduced to something if it works, but I actually think nothing works as well as just old school insulated Hardy's bayoneted bipolar forceps. Now, look here.
I completely agree with you with those forceps, Richard. We were just watching you using the shaver inside the sphenoid sinus. Do you have any words?
Oh, yeah. No, okay, yeah. So, Yeah, I was about to say, because there was ice in there, just for the sake of getting the ice out, I was like just shaving away the ice. But yeah, good point. I wouldn't normally just dip my shaver in. I'd be happy to do a little bit here to get some polyp out. But yeah, I wouldn't really operate in the sphenoid sinus until I found my corner pocket, which is what we're going to do now. So now that we've... And you can see actually, even in my hands where I've said to you, don't create two tunnels, I've got two tunnels still, right? So that's really important. So the next thing we're going to do is I want to remove the rest of this sphenoid face until I see up here. There's a little straight partition. So in here, can you see that? Tiny little posterior ethmoid cell, mini one. And now you can see, and I'll get a kerosene and point it out here in a moment. Is what Rod Schlosser refers to as the corner pocket. It's a great technique, you know, understanding the corner pocket concept. This is so important. So when you're doing surgery, you've got to make sure you can see this junction point right here. See, that's the medial orbital wall there. You agree? Do I need to make it clearer?
Yeah. No, it's very clear.
Medial orbital wall, sphenoid roof, you all agree? Whether or not that's this sort of the junction maybe between ethmoid and sphenoid. But this area here, where the medial orbital wall or orbital apex joins the sphenoid roof, is called your corner pocket. And the reality is that once you can see that now, you know where the orbit is, you know you've got your... You see how I haven't really cut the superior turbinate, I've left it pretty much all intact. I've left the middle turbinate intact, I've got my boundaries now. Now it's just a matter of connecting all the dots. So you know that the roof's up there, right? So you can take all this out. Does that make sense? And you just get rid of all this?
It does.
Yeah. I just, you know, I think we've overcomplicated FES over the years with trying to talk about all the embryology and how it all develops. Now, so you just bite that. You can do a straight through cut or a kerosene, depending on how thick everything is. So you can see I've just got a bit of loose cells here. But now what I do is I call it running the ridge. So I get all our fellows to do a thing called running the ridge. So they run that ridge from one side. So it must go from the, so you can see it from there, the superior turbinate, right across onto the orbit. There you go. So now we've done that ridge there, we'll do the next one. You could run from one side to the other. And I absolutely get people to turn the shaver towards the skull base and the orbit, because you've got to know where it is, right? If you're completely lost and you haven't found it somewhere else, then of course use your hand instruments. But once you know where it is, you've got to point the shaver towards it to trim it right off. That's why we use the shavers. But you've got to find it. You've got to find it first. So there to there, you can see how high up we are. And I often will turn the suction up and down in the theatre. So you can see I've got another ridge here that's, I don't know where this is headed. But what I can't see is I can't see the turbinate here on this side. And last time I checked, the ethmoid cavity was a box. There's the medial lateral wall of the turbinate, I should say, the middle turbinate. So now, can you see how I've just followed that ridge? That ridge. And you can see it from turbinate across to orbit. Same here. We know that the antroethmoid's in the skull base, so we don't have to worry about it.
Can you see the posterior ethmoid there?
In there? Yeah, just there, hey?
Yep.
Can everyone see it just behind that partition? There it is there. And, you know, I mean, I'd probably be pretty happy with that, but, you know, you can see here that you can even, you know, if you need to, you can dissect this, you know, you can bite that right up. But it's pretty good. And now, once you get to about this point now, that's about the limit that I'm going to have with a standard antrostomy. Like, I don't think I'm going to struggle to do any more without doing something now to the middle meatus. Don't you agree? I wouldn't try to be pushing anything at the moment. And what we'll do is we might pause on that sphenoethmoidectomy here in a moment. We'll go to the other side and we'll talk about some other techniques. Now, you can see how now that it really is, where this is the sort of typical surgery we would do for diffuse CRS, like polyps. The maxillary sinus, the posterior ethmoid, the antroethmoid, the sphenoid, look how they all connect. We haven't affected the stability of the middle turbinate at all. This thing here that comes across is over the maxillary sinus and the posterior ethmoid. It's got nothing to do with stability. And we talk about how low we come. I'd like, personally, Simon and Joe, to come as low as you need to get a straight sucker into the retroclival recess. If I can't get a straight sucker into the retroclival recess, then if the person gets crusting or mucus or something in there, I can't really deal with it in the post-operative setting. So if I'm going to open a sphenoid, at the minimum I'll do is be able to get a sucker into the retroclival recess. And that'd be like a sphenoethmoidectomy where I haven't really made a decision yet on what we're going to do to the frontal. What about we go to the other side and maybe we can talk about doing an SPA ligation. You know, I think, Simon, people leave SPA often in sinus courses until the very end after they've started a whole of surgery. And therefore, what they do, you know, the specimen doesn't look like it does when you're actually doing it for an acute bleed. So I thought maybe I'd take people through how we actually do it for acute bleeding. And we can use...
It's pretty easy to find the vessel.
Yes, exactly. So what we're going to do is we're going to come in, the same story now. We're going to use the sharp end of the freers. Let's make that releasing incision up here. You can see, just want to break through. See, I can hear it, you know, and feel it. Just breaks through the surface. But that's all you want to do. And look how it sits nicely now. Next we want to do is that we'll get into that. We'll open up an antrostomy. I don't do SPA ligations by making little incisions in here and working in this tiny little cleft. That doesn't make sense to me for a whole lot of reasons, and we can talk about it. By opening up that little space, coming in now, once again, coming in not here, but in here, stretching it back. Can you see how the roof mucosa, you can imagine if I pull down now, see how the roof's stripping, David? That's very important to keep that roof, you can keep it up, so go straight back. Then nicely here, if you're going to do something into the sphenopalatine foramen, you can be pretty aggressive at how far back you go, right? Because you need to go all the way back. But we'll take that all the way down, and automatically, especially in an acute case where it's swollen, someone's had a pack in the nose, all those sort of things, by doing this, it gives you that nice space that you need to work in the nose. Now, I don't even do an upper uncinectomy here if I'm doing this just for the sake of making an SPA ligation. I would just do the antrostomy. My apologies, I have to take my suction off. So yes, making sure that there's nothing left. So you can see that then, guys. Pretty nice, pretty good view of the back, right? And it really is should be very, very straightforward and quick. So now when we come in to do it, and I'll just get a nice clear view, this is the Richard Harvey rule for finding the SPA. You've bitten here, so you can see then the bone. You see that? Go as low as you possibly can. Once you found the right space, swap over to the blunt side. Go all the way back. It's cold. Until you essentially almost see the eustachian tube, and then just sweep up. And there it is there. I'm not super down with the whole cristoethmoidalis thing. I just take us all the way back to the eustachian tube, and if you're low and then you slide up like that, you just can't help but not see it. It tethers your dissection. You can't sort of go any higher. And that's how I find it. And that won't be the whole thing, right? That'll just be part of it. So what we do then, if we're going to actually deal with that, let me 2 seconds.
Can you just show us the cristoethmoidalis, which we can nicely see now?
This little spiky thing.
That's the one.
Yeah. I never know if that's the crista or this ridge here. Is that the crista? Never.
That's my understanding. It's that horizontal ridge.
The horizontal ridge, yeah.
It was interesting when you raised that flap, Richard. There were a couple of nerves you divided, and they're the posterior nasal nerve branches.
Yeah, it's true. Yeah, you'll sometimes get little vessels coming out there as well. So I use my Blakesleys to get a bit of the bone off, because I just want it to be as close to the sphenopalatine frame as possible. I generally use a 2 mil Keresins. This is a slightly bigger one, but we're going to make it work here. And you got to remove the bone. There should be on average 2 or 3 branches, and I think genuinely most people often will miss 1 or 2 if they're doing a SPA, especially if it's their first go. And often the posterior one, the one that runs onto the septum, is often your implicated vessel. So it's worth doing that to take a bit of the bone off. And this is the same that we do in the Vidian neurectomy. Maybe we can do the Vidian neurectomy after this. So take that away. You can see I've tried very hard to stay superficial to the periosteum of the PPF. Now, it's probably as much as you need to do for an SPA, but if I'm going to do a Vidian neurectomy, I'll take a little bit more, because I want enough space to swing this out of the way. I want to be able to swing the PPF in a more lateral position. You can see how limited just working through an antrostomy really is. Okay, you can see I've broken the periosteum there a little bit. So now we'll come in. Sorry, just give me 2 seconds to move the head. Okay, so here we go now. So there's now, you'll find that you'll have, that tissue will be going down in a canal through there, and you've got the vessels coming out. Sometimes you can dissect above it, and you can actually sort of almost isolate the whole area. And that's probably not a bad demonstration of how thick the SPA really is. Can you see that? It's between my freer now and that space we've discovered below. It really is very thick, that whole area. Because there's a fair bit in there, right? So let's cut that now. So normally,
in real life, what would you use to ligate or?
Mets and bums, just like I'm doing now. I use a pair of Mets. There's the vessel. See how there's a vessel at the back there?
I think what Joe's asking, Rich, is do you put a clip or do you diathermy it?
Oh, I diathermy, yeah, sorry. Yeah, I diathermy and then I cut it. I do both, because when I cut it, I actually want to see the
clips are no longer available. The ones with all the like the rivets, the fenestrations on it. Are no longer available. So the only clips we've got now just fall off very easily.
The ones that I do use in this situation, and I want to see this face here. So see this face here? So that's the face of the sphenoid. Can everyone see that? There's no more branches. Can you see all that? Pretty obvious, right?
So you can, and I think without dividing the vessel, you can never be certain that you're not looking at it.
Yeah, that's always what I'm worried about, Joe, is that unless I divide it, I'm just not sure that I've got everything. Now, so that'd be the end of an SPA ligation, right? And I just put a little bit of dissolving material in there. I certainly don't pack the nose if I've done an SPA. That's like hedging your bets, Okay, so what I do now is I remove, if I'm going to do a Vidian neurectomy, I'm going to remove this medial part of the PPF. So I just get a feel about where the PPF is heading down to become. Can you see that? The descent, is it greater palatine, descending palatine, greater palatine, descending palatine? I always, probably it's both. And you see that? See how I've fractured that medial wall off? And you get a real view that there it is there, and there's those little vessels coming through, as Simon said. But there's the triangular PPF heading down and becoming the descending palatine, nerve and artery. And then I'll take this off. Now, there's a couple of things we're going to do here. Make sure I got the right instruments. Yep. Thank you. Sorry, just making sure I got my instruments. So here we are now, right? Because I've mobilized this, and these vessels would be cauterized, you want to come in here and you've got to release the PPF from the what's called the palato-vaginal canal. So this is your first step at finding the Vidian. You've got to get that wall off, and you can see this. It looks like some sort of structure is coming into the bone here. Oh, that's a funky looking sickle knife. Now, if you said to me, Richard, why did you make such a big effort to find here? Because if you're not convinced that you're more medial than the PPF, you could be dissecting in the PPF. And therefore, you might end up, cutting some of the structures in the PPF, give someone unnecessarily a bit of a numb palate. So you see how I'm removing that? Now, I still think I've got a bit of bone here, right? This bit of bone is a little bit thick and I can't really see, so I'm scratching around to see if I can get that free. And I'll show you here in a moment. There's some little vessel. Look, see how there's a vessel coming through the bone? Like that can all go as well. You know that's not required for anything. And you've got to release that. Now see, this bone here is a little bit too thick. I almost never use a drill. I have to say never, but almost never. So see how I've been able to grab that? Yeah, there you go. Now I'm going to have a better view of that palato-vaginal. Very hard though. You've got to make sure you really get that palato-vaginal free. So you can see the vessel here. I think we're almost through it. Let me just get my sickle knife again. So you can see PPF is here. You can see the medial boundary to the PPF. See how I've divided this soft tissue here? There you go. How's your view there? Can you see what I'm seeing here, which you can see? Get that stuff off. See how there's a soft tissue going in a canal? And the canal is going almost horizontally in this direction. Can you see that? That's palato-vaginal. So if you see that palato-vaginal, it means then that you've at least got back to the face.
Often mistaken as the Vidian canal.
Correct. And then here we are now. So as we go through, so now you can see the Vidian. And now that you're back at this level, it's just a matter, and the Vidian, as it always should be, you just circle around. This is where my little bend in the sickle might actually help me, Joe. Might be able to use it to my advantage. You want to slowly and circumferentially dissect the soft tissue and define the bony limits of the canal. And as long as you do it essentially at this level where you're behind the PPF, you're not going to cause any harm. And you can see it often doesn't come in one go. You've got to do it like that. And it's a big nerve, right? So what I'm looking at now is not enough. And the whole PPF, because of the space I made, should move laterally. I still got a few fibers there that wouldn't be good enough in real life, and now we've got a situation. There it is there.
When you finish this dissection, Rich, there's a question saying, can you see the Vidian canal at the level of the floor of the sphenoid sinus?
Yes. Oh, well, it depends on the pneumatization of the sphenoid sinus. But almost routinely, I think we saw it here. I saw the hint of the sphenoid sinus over here somewhere. Yeah, so just in there is where the sphenoid sinus is. You often poke into it sometimes when it's well pneumatized. But there you go there. Anyway, that's your Vidian, and that's how big it should be, and that's the orientation coming straight at us. And you can see how the whole PPF has moved in a more lateral position. There you go. And you won't have caused any harm to anything by doing that. So it looks really good.
That's demonstrating really nicely the different orientation of the Vidian to the palace.
Okay, what about we talk about a prelacrimal approach? How's that?
Before you do that, there's another question.
Yeah.
Can you just show that releasing incision on the middle turbinate again, exactly where it was?
Oh yeah, sure, okay. Let me take off the upper uncinate, and you can see here in the upper uncinate I've just gone straight to the kerosene again. I'm just going to complete my antrostomy, right? And let me just very quickly do the same. Oh, maybe I should, before I take the buller, I'll show you that basal lamella relaxing incision. So there's the floor of the orbit. Okay, now, let me go through to answer that question. Where do you release? And what you're doing, if you said to me, anatomically, what we're doing is we're releasing the sagittal part of the middle turbinate where it joins the coronal part. So there's the coronal bit sitting at 90 degrees, and as it turns, this is where I'm making that release. Can you see that? And in most cases, Simon, it becomes just contiguous with my basal lamella opening and where I go into the superior meatus, I would say. I'm not sure about you guys.
You may as well do it at the start and get a better position.
And then up through here, straight up through it. Now with an up through cut. And we'll come on this side, we'll do medial wall, floor, crunch and gobble. You see how I'm not pulling anything out. Really important. And you can say that's why even in a cadaver, we can practice sort of mucosal sparing surgery. You know, I'm sure my learned colleagues will say even cadavers are worse than humans, you know. You know, normal sinuses are the worst, disease sinuses are the best, and cadavers even harder still to preserve it. So there you go, run that ridge. There's our, you know, so-called mini fess. There you go. And then here you can see my orbital floor becoming the medial orbital wall. You can see there's a little bit of posterior ethmoid cell or something happening there. Actually, even like just this ridge, you know, it's got to come off, right? Because it's hanging below the orbit here, that ridge. There you go. Now I'm absolutely convinced that's orbit, absolutely no doubt about it. The whole thing could be covered in tumour or polyps or scar tissue. I'd still be convinced that that's the orbit. So let's have a look then at the so-called prelacrimal. How's that? Should we do that next, guys? And then we'll do some frontal work.
One of the questions that always comes is, who do you do the prelacrimal on?
Yeah.
You know, inverting papilloma is really controversial because then you can't see it afterwards. You know, when would you use this?
No, I'm going to use it when there's a benign mass in the sinus cavity in which there's not going to be a whole lot of, you know, removal of mucosa, so we're not going to leave them with potentially a sinus cavity that doesn't work, but we just want access. And this is the person. If you're taking a lot of the mucosa of the maxillary sinus, Simon, in my opinion, you shouldn't really do this approach because you'll leave the patient with a tiny antrostomy to try to recover the situation. Now, with a diathermy, I don't use a blade in real life. I'm going to make an incision all the way down to here. See the piriform? Everyone see that again? There's the piriform. And the diathermy's got like a setting of 12. It's, you know, you don't need much. But I love that diathermy needle point. What do you guys use to make cuts in the nose?
Yeah,
it's interesting. Most people I think most rhinologists do that these days. They don't. No one uses beaver blades and things like that anymore. Don't you agree? I think it's most of my colleagues. Now,
I use the one with the 45-degree angle on the end, which is lovely.
Nice. Yeah, it's got to have an angle. You can see how awkward it is without an angle. Now, there's my incision, right? Now, I saw someone demonstrate a prelacrimal approach, you know, over in Europe, and they made this crazy little mini incision here. That to me is not how you do it. you want to create a giant U-flap that's based posteriorly. So it's as high as you possibly can go, as anterior as possibly go, and as wide medially as you can go. Because when you finish the surgery, when you finish dissecting all this, this will retract, and you won't be left with quite the coverage you think. So the first thing I do is, like always in the sinuses, I'll always dissect anything I can posteriorly and inferiorly first because of bleeding. So if I can dissect all of this now, before I start making blood superior to me, that's advantageous. Let me just dissect this out here. I'm going to lift that up here. I might not, yeah, there you go. And the nice thing about the diathermy, of course, is it gets you straight onto bone. Let's come up here. There you go. So now we've got the bone. Now let's find, I see how I left this transition zone here? I think maybe I wasn't quite on the bone. Yeah, I was right on the piriform. So that's another little dissection technique, is that if you get an area that's not, the dissection's not obvious, just dissect everything around it. And that's just me misjudging exactly where the piriform is. So I just dissected everything around it, so then I came in, and then up, and now I'm in front, because I was slightly, see that, just into the soft tissues. Now, when you raise this, you've got to lift this up, and you've got to come in here first. Once again, always on bone, always on bone. Let's come in underneath this, and now you have to get the bone out from the turbinate. You can't take the bone with you. Oh, I can see I'm taking a little bit. Bad boy. Let me take this. Now, see, I've got this now specular bone. So once you've got this little specular bone, you want to get rid of it. Sorry if I'm in and out a little bit. I'm doing my own instrument choices. See, I take, just like I did in that septal spur, I'll take a bit of that so then I can see the next level of dissection. Can you see there now? See, I can see beyond it, just like we did in the septal spur. Same sort of concepts. Now, you'll find here in a moment, we'll mobilize all of that. And we'll push all this back. And making it big often is advantageous to you because it allows it to fold back like that, which is nice. We don't have to go into the infundibulum. But can you see here now, it looks like I'm about to get this tissue that's heading up in that canal. And that, of course, is your membranous nasolacrimal duct heading up. Now, I do try very hard, if I can, to sort of get as much of this happening before I introduce the drill, because in the drilling it becomes very straightforward. There you go there. Can you see that? And now we've really got a very clear, once again, I have to be convinced, and this is now the sort of thin lacrimal bone that you might open in a true DCR. But here we are here. And you can get 360 degrees around this. Now, someone said to me, there are certain anatomical restraints that prevent you from doing a prelacrimal approach. Well, that's not true, really. You know, you can see where the anterior superior alveolar nerve is going to be. But if you don't have a prelacrimal recess because of the pneumatization of the maxillary sinus, as long as you mobilize the lacrimal sac, well, you just enter here. And you'll see in a moment, that's where I like to enter, because it's actually the safest place to enter. So instead of it being a prelacrimal, it's really like a perilacrimal, in my opinion. Let's put a drill on, and we'll open this up.
Richard, there's been a couple of papers published recently about where to drill to make sure you don't damage any of the palatine nerves.
Yeah, you can see it there. It's anteriorly, very anteriorly. So if you said to me, I saw some of those papers. They're very nice, but as a practical way, I'm going to put a bit more fluid. You never want to look at me. I don't want to burn the bone in the cadaver. So the first thing I do here. Say that again, Joe.
We've got a question about the possibility of injuring Hesner's valve.
Oh no, Hesner's valve's in that soft tissue. And really, at the end of the day, things like Hesner's valve is, probably given the pathology you're treating, is probably like of little concern. But actually, most patients don't get regurgitation up into their eye afterwards, or air escape. I think more people cause those problems doing turbinate surgery than this. Okay, so here we go. Apart from me poking in there. So I showed you pulling that crest off, right? I wanted to get rid of the crest so I could show you what to do next, right? Now, once you get rid of the crest, it is sometimes worthwhile then to get your kerosene, like you do in a DCR, and do a little bit here just to preserve the membranous duct, because it's nice if you don't get into the duct. The duct's very, very forgiving, though. You can cut it and do whatever you want to it, really, at the end of the day. You get away with.
Which drill are you using?
I'm using the Medtronic 30K 4mm diamond burr. So great burr for doing sinus work. Diamond, you get good hemostasis, it's fast, it's got a core. So there's our nasolacrimal, and I'll see if I can really, there you go, completely pulled out of its canal. Can you see that? I can see the bone now on the other side. You all agree? And it's great. It just means that when you come in now with this, so Joe, I haven't looked back at the scan just to see exactly how big, but as long as I open up in here, right, I guess perilacrimal, I know where I am. Can you see that? Now, my first thing I like to do is to remove this triangle of bone down here towards the canal. This we call is Snidvong's wedge, after the famous Professor Corncat. And we like to get rid of this triangle, because if you don't get rid of this triangle, you're forever struggling with not enough access into there. That'll be potentially a tooth root. We'll leave it for now. But now I can drill, you can see it's tooth root there in a second. Now I can drill and get all this back bit here without my shaft. See how my shaft is resting on there? That's so important, right? Now, you can't see the anterior face still, right? So you can still take this. And as long as you do it on a broad front, you just look out for the nerve canal when you do it, right? We just make sure that we're not going to... Sometimes you might see it in here. And if you see a bit of soft tissue coming up, you just pause to see if that's... You can see we're not in there.
I think, Richard, the fact that you see the teeth, gives you a brilliant indication for an odontogenic cyst or something like that.
Yes, exactly. I completely agree. And then, of course, your upper limit then is your orbital floor. Almost there. And I'm intentionally using the maximum width of my prelacrimal recess here. This person does have a prelacrimal recess because my drill's essentially in it now. But you can go all the way up to the floor. Almost. And you thin this out, looking for the anterior superior alveolar nerve. Although I think we can see it, it's more anterior, but I still go looking for it. You will have little venous channels and things like that thing. That's not the nerve though, it doesn't come out at that level. There you go. And I think that's about, maybe do a tiny bit more.
Always use a 0 degree scope, Richard?
Yeah, 0. If I can't see it. So that's my view. That's what I would accept as the start of a prelacrimal. So once you've done that now, let me put our camera in. So there's the piriform. That's all the bone. You can even thin that down a little bit more, but you can see we might get into the prelacrimal there. We'll start to see it. But with the 0 degree now, you can see the front wall is a partition. You can see the exit point of the V2 nerve. And exactly as you said, Simon, you know, I think if someone has like an odontogenic mass, something simple that you're dealing with, it's a great simple approach there. Oh, look at this person. Some sort of cyst, some periapical cyst maybe, or maybe it's just a mucosal cyst. Yeah. And there's floor there. So back wall, and that's zygomatic recess with my straight curette. And I think people often forget that the sinus cavity, the maxillary sinus, the face of it has that direction that it heads back in that sort of posterolateral. The front wall is not perpendicular to the sinus cavities. It's in that posterolateral direction here. So that we call that the front wall, but it's in that sort of posterior lateral orientation, and then that's the back wall.
Yeah,
and then
I think very few indications to go through the canine fossa anymore.
Yeah, I think canine fossa really has very few. Even just a puncture in there, to me, I think, you know, if you picked up a nerve and got nerve damage when, you know, there are 90-degree shavers and other approaches like that, I mean, I think that would be very unfortunate for benign pathology. I mean, obviously, different pathologies can temper different issues. Now, you can see here, by getting this nice thick turbinate, right, I can just put a suture into here. I put one there to start with. I like to put one here, David, one back and forth here. And then I usually try to pick this up and bring it forward somewhere here. But you'll see when it eventually sips back, it's looking beautiful now. It's artificial. It looks like this in real life, right? It retracts down a little bit. It doesn't quite sit exactly, but as long as you've made it big like this, it'll sit through. But isn't that, I mean, that's just, Bing Zhao really has to be credited with promoting the prelacrimal. That was his real promotion, and, you know, Bing did a great job at you know, talking to other rhinologists about this approach. It's not something we use all the time, but just a great way of avoiding a whole lot of resection here and creating a medial maxillectomy with just the extra healing and recovery. Now, I don't do it because of the middle turbinate. Things like, you know, I don't think you can be a real sinus surgeon if you believe in empty nose syndrome. I mean, that's a hyperventilatory disorder or anxiety condition. You know, we do it because once you put this mucosa back, you really have no raw area in the actual airflow passage, and this all heals really quickly, and the patient's recovery is really good. That's why we do it, and it gives you that great access laterally to the maxillary sinus.
Do you find with your sutures, it's easier to put the throw through the posterior part first?
Yes, it's a good point. It's a good point, Simon. Yeah, absolutely, I do that first. Now, let's head over. What do you think, guys? We head over and we talk about Carolyn's window. What else do you want to see? I've done a septum, I've done an SPA, I've done a Vidian neurectomy, I've done a prelacrimal, I've done a sphenoethmoidectomy. How are we going for time? I don't even know what the time is, sir.
Yeah, I've asked the moderators as to how much we've got. We've got another question about the steps of the prelacrimal. First step, geletonization of the nasolateral canal. Second step, translocation of the duct stage window of the anterior part of the medial maxillary wall.
And we always start with an antrostomy. So when you do a prelacrimal, you've always got to have an antrostomy, right? Because no matter what you do in the maxillary sinus, you can't leave it closed up in there. You'll get a dysfunctional sinus cavity. You've always got to do a nice big antrostomy so that post-operatively that you can examine and wash it out. Let's go on to this side then. Now, I'm going to talk to you about, you know, how we do frontal sinus surgeries. This is not some special extended technique these days. This is just how I do a procedure. In that it's a very similar concept in terms of flap. So there's the middle meatus there. So we're going to come and make a flap that starts here, very high, and once again, it comes all the way forward to the piriform. And I would make it and it's inferiorly based. So you got that high. Let me get to my other direction. I'm sorry, it's a bit painful to watch someone do a scalpel dissection.
The flap that you raised for Carolyn's window, do you suture the anterior edge?
No, don't do anything. And we take it down to about the level of the orbital floor. Can you see the orbital floor? But it doesn't need to be any lower than that. and here it goes down here, and it's got to be at least the root of the middle turbinate. Don't make it anterior to the middle turbinate. If anything, you're a little bit behind even, right? Because you're going to remove all that wall. See that? So let's dissect that out. And I have to give a shout out to Alki here, you know, because Alki, you know, I was doing flaps in different ways, and Alki said, oh, you should base it inferiorly, you know, and he was absolutely right. You know, actually making these flaps, whether you're doing it in Lothrop surgery, that's what we were talking about, or in this approach, this lateral wall flap, making it inferiorly based, just makes it so much easier. You can see because of that anterior down cut, it's very easy to see it. And so, you know, I can see what Alki was talking about when Alki said, you got to do it this way because that makes it a whole lot easier to dissect. And it was a great call of his, so I have to give him credit there. And then you can see here I'm not quite through the mucosa. You've got to be a little bit careful when you're not through the mucosa in real life. Don't just keep stretching it, you know, you'll start stripping stuff. And apart from making my dissection look a bit ratty, we'll just, there you go. We'll fold this down.
We've got 4 hours in total maximum time, including Q&A at the end.
And what are we at now?
1.5.
Oh my gosh, we'll have nothing to talk about. It'll be an early finish.
You don't have to use it all.
Okay, so here we go now. So that's how low you need to be, right? The whole flap has to sit flush like that. Can everyone see that? Yeah? Where we are? Now, if you've got the middle turbinate, you just stay lateral to the middle turbinate. But of course, just like in a Lothrop, if you need to, say the middle turbinate's been resected, we can just go back here and find the first, that's floor. So first olfactory neuron's even further back, right? So I'm not even going to dissect it, right? But you could. Say you ran into a problem where there was no middle turbinate, you didn't have any landmarks. We'll just do it like you would in a Lothrop. Just find the olfactory, first olfactory fascicle. Now when you then come to drill, it's a little bit like doing a Lothrop in the sense that I'll often start down low here just to create some space. And like all my drilling, you want to do it along a broad front, just like we do in temporal bone surgery. And there's nothing to drill here, right? I mean, what's going to be out laterally here? Nothing, just going to be periosteum and lacrimal. So as you come up now, see, I drilled down there to get some space for my drill, so I wasn't touching anything. And I do that in real life. And as you come up higher, you're going to find the periosteum quite quickly. And you want to saucerize it enough that, you know, you got a straight view. Just like when we do DCR surgery, you know, you don't want to have a situation where you can't actually see around the corner. So you can see how we've got a little bit of periosteum just exposed there. Can you see that? And that's probably lacrimal, right? So now that you've got that, you take away what's called Ritter's triangle. So Ritter's triangle is this triangular piece of bone that I'm drilling now. Can you see what I mean by triangular? Do I need to maybe point that out? Here, this bit here. I'll mark it off. See, like that. Uh-oh. There's my irrigation. I want to know where my irrigation had gone. Seem to have lost my irrigation, guys. 1 second. Got it back. It's just the... Yeah, if we could pour some more water into that bowl, that'd be great. You don't want to, you always got to have great irrigation when you drill. Stops your drill from getting clogged, allows you to see well, stops you burning bone in the real life situation. But like even in a cadaver, it's important, right? So you can see this solid bit of bone here. You've got to get this off. And what it is essentially just the front wall of the frontal sinus. And so it's a bit like removing the bone that PJ might have done with and I'm just going to put a suction on here 1 second. Might have done with a, an auxiliary flap. It's what Jim Palmer would have done with a kerosene, but just doing it much more aggressively. So it's not something you can do without a drill. You've got to have a drill to do it.
Question raising about flaps. Do you use cautery? I think that's the,
Oh, yes.
The previous comment. We always make the incisions with cautery to minimise bleeding during raising the flap.
Yeah, needle point cautery, and like on a Vidian diathermy machine, something like at a setting of 12 is usually enough. Now, can you see how we're about to break through into the frontal recess here in a second? Can you see that?
Yep.
So you just got to, and you do drill a little bit with the pole of the bird in this technique, right? So occasionally you saw me, I had to unblock my drill, because of course in the Medtronic gear, the suction port's at the tip. So just whenever you drill with the pole of the burr as opposed to the equator, you can make that happen.
Can you talk about what sort of cases you choose to do in
Everyone.
Everyone these days.
Yeah, if I'm doing any sort of frontal sinus dissection, this is my standard technique. And you'll see here.
That's quite aggressive, Richard. I know that the field is changing. Do you think it gives you better outcomes than just a standard?
Yep.
F2?
Yep. And there's even a couple of papers by some colleagues in the US who've shown that with that bigger middle meatus you get with that 0 degree view, you actually end up with better irrigation and all sorts of things. Yeah, and it's just a whole lot easier. I mean, we're not talking about removing much bone here. We're talking about the tip of my thumbnail, So it's not a big area of removal. But
a lot of concern about, disposable costs. You're adding the cost of a drill.
Yeah, that's true.
Potentially 2 other microdebrider blades.
Oh yeah, no, I'm very cautious. If you're going to use the drill, then you can't be opening the drill and like an angled shaver. That doesn't quite make sense. You might as well.
You might not need the RAD 60 or something.
Yeah, exactly. No. When you finish this technique, there is no using angled instruments.
The drills around the same price as the oscillating blade?
Say that again?
Are the drills about the same price as the oscillating blade?
I think they're about the same, yeah.
And Richard, do you end up using the 0 degree scope for the entire frontal dissection for most cases?
Oh yeah, exactly. Exactly, I just end up using it the 0 degree for the whole thing. And so you can see I'm into this bone here. This is the bone that you need to be drilling. I buzzed my nasolacrimal unfortunately there for you guys, but we'll. But here you can see that's frontal recess behind us, right?
Richard, we've had a question about how to avoid, obviously you're well in front of it at the moment, but how to avoid the anterior artery when you're approaching the frontal?
The anterior ethmoid artery.
Yeah.
It's on the skull base. It's behind all of this. It's on the back of the frontal recess, so you can't get it here. On the wrong side of the building. If you had a skyscraper and the skyscraper was the frontal recess, you're working on the front wall, the anterior ethmoid artery is on the back wall. Maybe that's a good way of thinking about it.
Perhaps if you had a chance to look at the surgical scans again, you might be able to show that.
Yeah, sure. Now, so you can see how I've got my periosteum here, and I'm drilling this hard bone here. And you can see I'm just getting rid of that bone. And you just want to drill right up in that sort of pocket, right? And you do, and I really try not to break into the sinus cavity. So I like to drill all this bone a little bit with the pole of the burr. I mean, I know that you can see that you can enter there, but I try hard not to because if you just get rid of all this bone, so you can see it thinning out at the top here. You'll poke through like you do in a canalplasty in ear surgery, from what I remember of ear surgery. See how I'm about to poke through up here? So that's what I try to go for, not down here. If you find something down here, all you found is like the bottom of an intersinus septal cell or something like that.
I've got a question. Is the ANC away from the Caroline's window dissection? I'm not really sure what the ANC is.
Anterior, I don't know, Agonasi cell?
Agonasi cell, maybe?
It's Agonasi cell is part of your frontal recess. So we haven't frontal recess yet. So we're still sort of in front of the frontal recess. The frontal recess is through this tissue here. That's why it's such a safe approach. Like when you do Lothrop surgery, you know. Lothrop surgery coming from the front just becomes very, very safe because I could probably even remove this because you're coming at it from front to back. And I've really tried hard to take as much as I can without getting into it yet. And I'll just and you know, it does have a narrow opening, but you'll see it here in a moment. See all that? Oh. And I can see my approach maybe needs to come a little bit more anteriorly. Yeah, just the frontal beak, yeah. And now I'm going to use the equator of the, yeah. So you really try to, yeah. I buzzed the nasolacrimal, the sac actually on the way in. I would never do that in real life. So here you go here. And you know what? That would have been quite a hard, I think, frontal sinus dissection just with the angled instruments. We'll see in a moment, and I'll show you. So we haven't even done the dissection right. All we've opened up into here, oops, and I'm just getting blocked, is I've just opened up into the frontal sinus proper. So all we have now is this very thin anterior frontal sinus wall left behind, and I'll show you what we do to do the dissection. Can you see that? Can you see how there's an intersinus partition almost right in the middle of where the frontal recess would be going? That'd be most unfortunate when you came up to a 70-degree scope, but with the drill, never a problem. Okay, good. So you can see now, look how I can see right up into the frontal sinus. You can see in the apex. But there's no frontal recess surgery done yet, right? We haven't really done any frontal recess surgery. We've got to now do the frontal recess surgery. So let me actually, there's your front wall. And I'll show you then how we get rid of the frontal recess cells. And I agree with you, Simon. If you had like a really big, wide frontal sinus and, you know, easy dissection, yeah, you don't need to do this approach. But then again, in those cases, when you do actually do it this way, you're not actually removing much bone. It's already widely dissected by the pneumatization. So this is a case in which actually it's absolutely one that I would do with this technique, because it's quite narrow and difficult access. So let me see. I've got my shaver back on now.
If you've got frontal ethmoidal cells, does that change this approach or not?
Not really. Not really. So now with the kerosene, can you see this? So let's just orientate everyone to see where we are. So when you put this mucosa back, right, it covers almost everything that you've done. Almost. Can you see that? I'll leave it down there for now.
So from a 3D perspective, there's a question saying that people finding the 3D a bit difficult to analyse.
Okay.
So presumably you regard it as a mini draft 3?
No, it's just a frontal recess dissection. It honestly is. It's nothing more than a draft 2A at the end of the day. So you're just keeping it straight. Yeah. And removing that Agonazi complex. Because you found the medial orbital wall, can you see it there? We then are now with great preservation now of the mucosa of the frontal sinus, frontal recess, we're going to now take this away. And you can see how I told you not to go into that space over there. See how close that is to the skull base? That's the wrong angle. And look at this. What a horrible, awkward little frontal recess if we'd had to dissect it. I'm so pleased. I was thinking of doing angled dissection for you just to compare them, but you know, can you see that? That's the frontal recess. That's what you would have been presented with. Can you see that? Through a 70-degree scope. You agree?
Yep.
So let's go back. So I'm going to actually take the shaver on. I don't need it. I'm going to go back to the drill because you can see that the bone got a bit thick on me there. Could you see that? How I couldn't quite bite it with a... And I didn't actually realize how thin and narrow the frontal recess was on that side. So let me do this. Now, I still do a lot of draft 3s, but like when someone doesn't have much disease or it's just a barotrauma or something like that, then this is how I do it. Or I just need to display the sinus cavity. So here we go here. So you can see this bone. So you see now, maybe that orientates people. You can see the posterior table, and you can see how I've left because it disappears laterally, I've left the front wall, the frontal recess, just a little bit too thick. But great now that you can see the anatomy because you understand where we're drilling, right? This is why it's so safe, because you're in front of everything. And I do like to finish it off with a kerosene because I think doing that actually really helps you to preserve the mucosa, because you ruin the mucosa on the front wall side. You really want to keep the mucosa on the sides and everywhere else. Yeah, so what a great case to demonstrate this. Because you have an easy case that's got a big wide open frontal recess, Simon. I think the advantage is lost of doing this approach.
Head position, really on
Oh, yes. Yeah, well, I've had him always in a little bit of head flexion. Let me see if I can get it now with this. See, I'm still going to struggle a little bit. Straight kerosene, not quite going to do it for me there, I don't think. I do have what's called an articulated kerosene, so we'll try this. But very big. Can you see that? It's very big. I still like using a baby Hoseman or articulated just to take that bone, but I'm not doing it. I'm not doing it with a
fixed angle.
Yeah, it's a fixed angle. This one, correct. And I wonder if I've got a punch. Often is the other thing that you can use in this situation. But the drill always works as well. So you can see here, I've got that tiny bridge. Let me break it down. I'm not going to be able. I need to make it at least thin enough that I can get to it with like a curette or something, But it's going to show you. It's going to show you how awkward, tiny. So can everyone understand? That's the frontal recess. That's it. Can you see that? Crazy and thin, right? Don't you agree? What a horrible thing to be presented with, doing an angled instrumentation. See that? That's your frontal recess. And I'll just get my view a little bit better.
So if there was significant frontal sinus pathology, realistically, your only other way of managing this would be a draft 3?
Yes.
Yeah.
Okay. So what we'll do now is we'll put our flap back. And you can see just for everyone's sake, can you see that little area there? That's where I buzzed the medial wall of the lacrimal sac. So you do need to show in real life a little bit of care there, just to leave that soft tissue opening intact. This goes back on there. Now we haven't finished off the sphenoethmoidectomy, right? So we're still going to do that.
Do you get much post-operative stenosis of that window?
No, like very little. It can suck down, but if it does do that, it's not such a big deal because I do it as much to do the dissection as I do for any sort of as well as post-operative access. So even if you get a little bit of stenosis and closure, you're not doing it in a case, Simon, where you need a giant opening afterwards, you know. But generally, you get like a pretty good looking. You get a pretty good looking cavity at the end of it. Now, can you see this here? So I'm just going to go back to finding the running the ridge. So there's that cell there. We would take that and see if I can run the ridge right across to the turbinate. And that's probably antrostomy artery now and there. Can you see that? Might have drilled onto the dura there.
So even though it's in the skull base, it can potentially be damaged if you're going to do that.
Oh yeah, of course. You can see it now running through there. So here you go now. Here's this skull base. So you can see the skull base from here, all the way up here. There's the antrostomy artery coming all the way up, all the way up into the frontal sinus. Can you see that? Fantastic. So that's your sphenoethmoidectomy with like that sort of Caroline's window approach. You know,
is that the contralateral frontal as well?
No, it might be actually. Let's go back. Do you want to flick to the scans? Let's have a look. And I promised you on the scans I would. I'd keep it up. Oh, here. So you should be able to just see the coronal. Can you see the coronal? So yes, Simon, is everyone looking at the scans?
Yeah, we can see them.
Yeah, so I think you're right. I think it is actually the other side.
Oh, that intersinus septal cell.
Yeah, yes, exactly. Yeah, so I think there's that partition. But look here as we go back through it, that's that tiny, there it is just there. You know, it's like a really small sort of frontal sinus on that side. Should we do the other side? What do you want to do next? So that's Caroline's window. But can you see how the access is just very, very easy, you know, when you do it that way. And if you said to me, what else do I do for to get it to heal right? I'll normally take a little bit of soft tissue tail and I'll cover that area there with the soft tissue tail. Can you see that?
So just as a free turbinate grab?
Thin it right down and I'll cover this little last bit here. But look how much I've got raw bone, Simon. 1, 2, 3, 4, like 4 or 5 curettes, you know.
Yeah.
My normal first year registrar creates that in a heartbeat in the ethmoid, you know, when I just turn around, you know. So I think it's pretty good. You get away with it, but a free graft often helps. Now,
what sort of dressings do you put up there when you've got the free graft?
What sort of dressings? I use a free graft. I fill it with a thing called pure regen, which is like a hyaluronic acid or gel. But you can use a thing called Solugel. That works really well. These are my options that I often go to.
Right.
Do you use nasopore at all, Rich?
Only in Lothrop surgery to hold the silastics. I don't like nasopore sitting on raw surface because it forms some adhesions. But I do use it in pituitary surgery. So when a flap goes in on a pituitary over the sellar face, I'll put nasopore there because once again, it's not sort of absolutely on raw tissue. But if I want things to heal well and remucosalize, I don't like using nasopore. But as a support, I do. Should we do a DCR on this side maybe, you know, guys? So one of the things with the DCR, we've made a cut up the top, which is about what you should do for a DCR. This is a bit too anterior for a DCR, so I'm going to see if I can mimic what I would do in a DCR. So here's my cut there.
At some stage, Rich, we're going to need to see where your flaps would be for the draft 3 as well. I know you've got the Caroline's window.
Oh, yeah. We might not show. Well, in a real situation, I just do 2 lateral wall flaps. I don't try to take the septal mucosa. The septal mucosa for me rarely is of good quality. It's usually too thick, in my opinion, for most people, in order to use as a Lothrop flap. In polyp patients, it's often involved, so I don't often do that fully extended flap. But I certainly, when I do Lothrops now, I do it with those 2 lateral wall flaps that we described just then. And this would be about what I would do in a DCR. I think half the time too, Simon, when I'm asked to, like, fallow, or someone says, oh, let's try to raise it from the lateral wall across onto the septum, I think half the time I tear the flap, going across the roof there. It's not really its natural site of blood supply, and I do think it helps if you can make it happen.
Everyone's trying to find the holy grail of a drug 3 flap, and I think it's fair enough to say no one's succeeded yet.
Yeah, there's a bit of practicality issues in some of that. So here we go now. So that's what I would do. So I've returned my flap, right, but that's about what I would take for a DCR. And if you said to me, Richard, how much do you take? Well, I take it high as I possibly can and low enough that I capture the area where the bone starts to splay open. And you can almost see where it is, right, from my previous intervention, right? Now, you can often start then by getting into where the lacrimal bone is in a DCR. I'm trying not to bite my flap, and you put a kerosene in. See, starting at where the lacrimal bone is, and see if we can take that front wall off. Can you see that? That's coming pretty nice, because DCR is like even a smaller operation still. So now we're here on this side. We'll take off this little bit of bone. You can now see what is the nasolacrimal duct coming up. Can you see that? And then this is the sac here. Can you see that? Now, you've got to remove all of this, right? You will never see the common caniculus unless you take that all away. I mean, what do you think, David? I always think probably the biggest cause of failure is people not exposing the common caniculus. What's your experience?
Yeah, I'd say that, yeah.
And not removing enough bone, maybe.
Yeah, and getting some scarring as well, part of it.
So we're going to use the same drill. Now, one of the nice things about diamond drills is that you can define the front edge as well. So I often like to see the periosteum in front of the nasolacrimal sac. I think that's very, very useful. So I'll often like to see that, right? And of course, when you do DCR, you should always expose the Agenasi. It's like traditionally, and you can see how easily we got into it on this side, right? So my irrigation's just popping off here, guys, so my apologies. Everything looks like it's going along nicely, but just popping off. Let's try again. I just turn my irrigation down. So getting rid of all this bone and making it in continuity with the Agenasi is very, very useful. Because one, by drilling more, you expose less bone. Does that make sense? I often say that about Lothrop surgery, Simon. And it's sort of like doing the same bone as you do. When we've got front wall mucosa of Agenasi, sac, we're still not high enough, right? I can tell you now, our common caniculus will only be just on view probably now.
Do you use a lateral probe to tell you when you're high enough?
I usually just drill until I see everything, actually. Like until I almost see, I almost got my sac and my roof touching. But yeah, absolutely you could though.
So this is from the process of the maxilla.
Yeah, it's the same bit of bone, right? We drilled before, right? Yeah. There's Agenasi. And look, once again, to hold my words for true, more drilling equals less bone. Can you see? Look how much less bone there is by a little bit more drilling. What do you reckon? Enough? The peanut gallery?
See, I like to go one drill above where I see the lateral probe pushing in. One drill width.
Okay, very close, right? Now, when you're doing it, there's a couple of things that you should try to get out. So, you know, I've shown you now, like exposing. Let's get a curette. See this here? Exposing this. So that's your sac, right? Guys, can I get someone just to give me? Can I get some of that detergent on that? You know, actually, I was a bit worried I haven't done enough, Simon. You know, because see how in order to leave this flap and make it look sort of pretty, I've left myself maybe a little bit short. You know, I never want to look around a corner at a DCR. Your DCR should be like this, right? There's my there's my agonasi. Can you see that? And you can see there wasn't that much more between that and, you know, the frontal recess down here. Well, maybe I'll just suction that out so you can all see it. But look, by doing that, I mean, some people might say it's aggressive, but actually by removing all that bone, you actually make it easier and it's better healing for the patient. People who leave a lot of bone around their ducts, it's in external surgery, that's one of the principles. You've got to free up all the bone from around the duct. So I would encourage you, just in that, on that gauze, thanks. Yeah, fantastic. Just a little bit.
Richard's a question. So can we say that Caroline's window is drilling posterior-superiorly above the lacrimal sac?
Yes. It's exactly right. Yeah, no, that's a good call. Whoever said that, it's about right what it is. Now, so there's our lacrimal, and you can see how I was picking out the bone there between, because I want that mucosa almost to come in. See how they're almost like in continuity. It really is a different procedure to some of our big polyp patients and tumour patients where we rely on a lot of secondary healing by secondary intention. There's our sac. I'll push it from the outside. Golly, let's see if I can even get it. The person's had some eye surgery, so they're in need of something. Okay, here we go.
Definitely. So, Rich, there's been a question. Do you ever use an osteotome, or do you always start with keratins? And where do you put that first keratin bite?
The lacrimal bone, so where it's thin.
Right.
I think we sort of lost it a little bit because I'd done my prelacrimal approach.
And do you routinely place tubes or stents after a DCR, Richard?
I do, yeah. I use an infant beaker.
It's interesting because the evidence out there is that there's been RCTs showing no difference.
Yeah, I think it's minimal.
In Australia, there is another code for putting tube in.
Yeah, no. I think if you do it, you're doing it really for patients. Like if you don't do it, you just have to be very convinced that your lacrimal blockage is solely at the level of the sac or further down. And
how long do you leave the stents?
Some people have canicular block and all sorts of little webs around the common caniculus, and so there are other things that you might be doing. Sorry, I'm just putting the eyelid on tension. But you can see I can find the hole, but every time I do it,
But how long would you leave the stents in?
3 weeks.
3 weeks.
Yeah, so not super long. I'm going to try to do it. Nope. The problem I have here is that there's not enough tension. And I've got no lacrimal dilator. Okay. This is when you're all by yourself doing the surgery. Okay, there you go. There you go. There you go. And look how where it is, right? Right up the top there. Can you see that? So we certainly didn't put in too much. You agree?
Agreed.
Yeah, because I think...
Perfect, almost exactly 1 drill width above that.
Yes, the Carney rule. Yeah, I was right on it. Correct. Now, sometimes if you're not sure that you've just come through just the front wall alone, give it a bit of a suction, and then get something blunt to enter the sac, and then come up underneath, like that. Because I think if you do that, it just makes you sure that you're not going to cut the lateral wall as well. Because I don't think it matters really what you do to this wall. Like whether you preserve flaps or you know, a lot of people discuss just shaving it away. I think that's all. You can do whatever you want to these flaps. It's as long as you've got a relatively good preservation. Oops. Oh, I'm in a false passage. I'm sure I am. There you go. Because, see, but look how high up it goes, guys. Can you see that? For those of you who thought we were already high enough. Let me see if I can. It never surprises you how high it is. And it's good to do all the drilling first, right? You don't want to be coming back and doing more drilling once you've got it all exposed, you know.
I suppose, Richard, the other reason why...
There it is. There's a common cuniculus. Look at that. Yeah. So, right at the top there, right? So I even sold myself a little bit short, I think, guys. I might actually take a little bit of bone off from here. Yeah, sorry, what were you saying?
So that's taking all the bone off also helps with the way the flaps sit after this. Is just what you were about.
Oh yeah, I completely agree.
Right.
Yeah, I completely. You got to have it almost like saucerized, haven't you? Saucerized, does that translate?
Yeah.
So I thinned it out, but I could have even taken more. If you've thinned out the bone, you can finesse it with a kerrison, but you can't take all of this just with a kerrison alone. But what a great example of, you know, it's actually much, much better to show a case where we really have to fight a little bit. That's what the common cuniculus looks like. I reckon there's some DCR surgeons around the world that have never seen that. It's like a little poochy eye. Can you see that? Yep.
Yeah.
And then
very clear.
And very clear. And then, like, how much further does the sac go? There. That's where the sac ends, right? So exactly what Simon said. You've really got to be almost like a drill above where you think the sac ends, right? There you go. But you can imagine, fold the flaps back, make them nice, and then Bob's your uncle. You've got your DCR done. Take out all these little bone flakes, of course. And you've got to dissect this sac all the way to the bottom, right? Because if you don't do that, you can get like a little funny something happening here. So it's worth marsupializing the whole sac. Oh my gosh, what are we up to next?
There was a question, Richard, about showing the AEA, the neurectomy artery, and how to ligate it if it's bleeding. Wonder whether you have the opportunity to
yeah,
show
okay.
that.
Well, what about we dissect this side? How about I do the...
We've got a medial maxillectomy to do, and then a draft 3, and then infratemporal fossa.
Okay. Okay. So why don't we leave that? Because by the time we do draft 3, we're going to be done there, right? What about we do medial maxillectomy? Truth mortal artery, and then we'll do medial maxillectomy. Okay, so let me just get my suction power back. So let's go up here now. Okay, and let's go up to the antrostomy artery canal. So this one's clearly in skull base, right? But if I was doing like a tumour or something of the skull base, I do actively take this vessel. And so I'll show you how I'll do that. Sorry, okay. I got my instrument. So, you need an instrument to pick off the bone. So see there's a thin bone over the top? You want to pick off the bone from the front wall? And you can find it that way. So that's one option. The other option is to fracture the orbit. I'll just make sure it's not too easy. Fracture the orbit down here, and then you can, with the blunt side of a freer or something, fracture the medial orbital wall. Can you see that? Like you might be doing a DCR. Or orbital decompression, I should say. And then when you get close up to the frontoethmoidal suture line, which is here, as you dissect it, you'll see it go over the roof there like that. Can you see that? And this person's got a middle artery as well, which is described. And then you come into the front, and you can get either side of it. You can actually see it tether like this. And it's obvious here now, but if it was totally in bone, that's all you would see, would just be that. And once you see that, you can just fracture that off and get rid of the bone around the orifice. I do like using a curette to do most of that. There's no room here for keratins and things like that. Can you see that? Then once I've got that, I generally like to use the small end of one of these probes. But see, this probe's only got two big fat ends, so it's not going to cut it. Let me have a look. I see. Oh yes, Olympus have brought along a nice small look here. If I can use the small probe, it's better. Because then you can actually see the other side of the canal. Now it's very, very important to appreciate how tough it is, right? It's not something that you just touch and suddenly breaks and retracts into the orbit, right? There it is there. And I think that's such an important thing, because I think some trainees have been taught this dictum that somehow the antrostomy artery, oh my gosh, if you touch it, it's going to break and bleed. Let's be honest, the people who really broke it, back in the day of early FES, they accidentally tore it, either with a Blakesley or shaver or something else, and that's why it did some terrible, retraction back into the orbit. I think probably modern day skull base surgery has probably proven some of those myths not to be as valid as they once were. And so you cut it obviously on the lateral lamellar side. It gives you a nice free stump now, and that's what you would then cauterize and seal up. How's that? A couple of different ways of getting there. If you can see it, flake it off. If not, come into the orbit. And then of course, just for the sake of those who are interested in orbital surgery and everything else, once you've done that, you're free to dissect up the top. See that? But you can't do that normally because anterior cranial fossa is on the other side here. Look at this person. I think, oh no, that's our posterior, isn't it? Yep. Oh, maybe. Yeah, that'll be our posterior looking at it. I thought there might have been a middle artery, but that looks about it. Posterior is usually pretty small. You can sort of just treat it poorly like that. Oh no, there is. There was sort of two vessels there at the end of the day. David or Joe, whoever was talking about it. So there is described as sort of middle one, But it's like Simon, when you're talking about the vessels coming out at the vertical plate of the palatine bone, you often see different ones. And so that's how people talk about getting laterally, and that's how you can even get more lateral and over the top of the orbit. And of course, you know where the optic canal is there, so you're pretty safe. You can do whatever you want up there. Okay.
Quick question: if you're not putting a stent in a DCR, use anything to hold the flaps in place?
Once again, I use that pure region, that hyaluronic gel. You can use Solugel as an option. I think in that setting, because you're on mucosal surface and there's not much raw bone, you could probably use Nasopore, you could use a bit of gel foam. I just don't like using things like Nasopore and gel foam when there's a lot of raw surface. let's have a look here. So, medial maxillectomy, right? Or modified medial maxillectomy, should we say, Simon or Joe? What do you guys call? I call it modified, really, when you. And the whole purpose of modified is we're trying to preserve the nasolacrimal duct. So when you do a modified medial maxillectomy, I like to crimp that section of the middle turbinate that we're going to remove. There it is there.
I do exactly the same thing, Richard. And you mentioned earlier about the so-called empty nose syndrome. I know what you're going to say, but for the sake of discussion, do you ever warn patients that you're going to be removing a large portion of their
No. I don't. I don't. I honestly, I think that there is no scientific basis for the idea that taking someone's turbinate produces empty nose. And if you look, actually, I think there's a recent systematic review in the White Journal that looked at a systematic review, all the studies that explored the pathophysiologic mechanisms of empty nose, and actually whether you had turbinate surgery and how much of the turbinate and how big a space you have, it's got nothing to do with whether you develop the condition at all. It's actually more got to do with how well you as a patient associate with things like hyperventilation syndrome, anxiety, somatosensory disorders. So I really think we've got to start changing the concept here. I mean, when I was a trainee, that was accepted, that there were a bunch of patients who had like a hyperventilation type syndrome but of the upper airway, don't operate on them. And somehow people, often for their own gain, have turned it into a condition again that's because of reduction of the turbinate, and they've done it because they're doing things such as implants, injections and things at greater cost to these patients, and they're financially benefiting from it. And I think that's a real problem in our society, and we've got to be very careful about that, So that'd be my take on it.
Yes, I agree. And unfortunately, there are sort of Facebook groups devoted to the syndrome, which continue to perpetuate this. Fly to the States and have this doctor put an implant in your head.
Yeah. Yes. So some of those websites, are actually established by the doctors themselves. So that's talk about the conflict, right? Now, I mean, there's no doubt about it, there are some people who have a sense of nasal blockage, that feel like they can't breathe through their nose, that they're suffocating, just like people who have hyperventilation disorders do, and they seek out interventions, and they usually see several ENT surgeons, most of whom say, look, I don't think much is going on, just use the nasal spray, and they eventually find someone, sadly, despite talking about their nose in a way that doesn't really make sense, that it doesn't really link in with an allergy or another cause of rhinitis, that they just have a general sense of blockage that doesn't meet any other pathophysiologic concepts, they get an operation on their turbinate. And often empty nose patients are very quick to dismiss the reason why they had the original turbinate surgery, and they just like to blame the turbinate surgery. But the reality is that they all had turbinate surgery for the concept of blockage. I mean, that's the only reason people do turbinate surgery. And then, after surgery, there's my Hasner's valve, guys. Can you see that? And then after surgery, they have these enormous, and you'll see there's some research coming out in the next couple of years. I've seen it, as a reviewer and also as someone who's been asked to be involved in it. These patients have enormous expectations of what this surgery is going to achieve for them. It's going to make them feel better, refreshed, sleep better, overcome their tiredness and all the problems they've had. And of course, you can imagine the turbinate surgery not only doesn't deliver on all of that, it actually, of course, for a short period of time, like everyone, makes things worse. They actually get a bit congested. And that's why you hear these stories of people waking up in the recovery room, panicking and I can't breathe through my nose. I mean, all patients get that, right? But these empty nose patients are so fixated on it, they have this hyperventilation, that's why they wake up. And of course the surgery doesn't deliver, and it's like as if we did some lung procedure on people with hyperventilation disorder. The whole event is traumatic, it's what's called a conversion disorder. And the conversion disorder then sets the whole thing off for these patients, and they It's much easier to blame the surgeon for something they did in the operation, even though people who, even in the field of empty nose, say that it's actually not related to how much turbinate surgery, it's just having turbinate surgery. I mean, it's a pretty harsh call to say that, but they blame the surgeon for their problems in life rather than accepting the fact that they have hyperventilation. And you know what, hyperventilation patients do that too. The doctors can't work out what's wrong with me. I keep going to hospital for breathlessness and breathing. They don't know what's going on. You know, it's almost the same sort of language that we see. But unfortunately, in our world, someone's given them an operation and hasn't delivered.
Richard, the question, do you always preserve the posterior end of the inferior turbinate?
Yes. Leave a little stump there so you can bipolar it. You don't want to leave it too big, but I certainly leave it. Now, I was about to say, I've been talking about empty nose, Joe. You got me distracted, and I haven't talked about the flaps. This flap has to come all the way forward at this sort of 45 degree. Can you see that? So the back one is 90 degrees, but this front one has to be 45 and coming towards us. Like that. So you preserve the mucosa laterally, and then you expose Snidvong's wedge again. So that's really important to get Snidvong's wedge exposed. You guys do anything different?
For all the attendees from the subcontinent and all the cricket fans, Australia just won the first test.
Yeah, no. Thank you. So here we go now. We're going to drill in just like we did before. Somewhere where, it's obvious we're going to get into the sinus cavity. I just like to do it where it's obvious. And I like to do it sometimes just so you can see exactly where you are. Make sure that you're not not anterior enough, too far anterior. You can see now I've got that right. Now we've got to take Snidvong's wedge, otherwise we'll never get the drill in.
Just a quick question while you're drilling. Have you ever had a patient with a stump syndrome after a DCR?
After a DCR? Yeah, yes, absolutely. So I've seen it. And it comes about from not removing and marsupializing the rest of the membranous duct. So if you leave the person with a obstruction in the distal duct and you haven't marsupialized the whole duct, then they get that sumping. Yeah, yes, absolutely.
So you can revise them.
Oh yeah, easy revision. Easy revision, but prevention is better than cure, of course, Simon, in that situation. Once again, it doesn't give us that anterior view that we get from that prelacrimal. And here we go again now. We're gonna get rid of, see how I've got Snidvong's wedge happening. Can you see how low I've gone there?
No concerns about going too close to nerve?
No. Anteriorly. Anterior superior alveolar nerves. The only thing you have to worry about there. And so I just thinned that out a little bit, because obviously we've got to connect it all up. And I do like to thin this backbone out and remove the last of it with a little Blakesley forceps, because you don't want to drill into the descending palatine canal. So you've got to, as you come back here, just have to be wary that the descending palatine nerve and artery are going to be in here. Now you get a good view of it because you can see the back wall now. So you know a little bit more to go, but you just got to be conscious of it. Okay, so I'm going to take that for now. Let me put a shaver on. And we'll get rid of it and we'll connect it all up. And I'll fold that flap in so you can see what's going on. And you do want to make sure you get that bone. You don't want to leave a whole lot of bone there. And you want to make sure all this area here, that you don't leave much in the way of exposed bone. You can get crusting back here. I'm sure you guys have seen it. You know, and it's one of the reasons why, you know, medial maxillectomy is not morbidity free. Now you see how I'm taking that bone and just twisting it? But look here, look where it broke off. Can you see where it broke off? Just that little point there? That's the descending canal. And so that's why twisting this last bit off is just a great way of getting rid of the bone without damaging the nerve or vessel. And then of course you can see then the inferior turbinate artery, which would need a buzz. Let's put our flap back down. So you can do whatever you need to do now in here. You might need an angled camera to see just around the corner. You know, it gives you the ability, if you want to strip the mucosa off the floor, you can. And then this flap folds in. Once again, you get this lovely coverage, Joe. It's one of the biggest things I think in sinus surgery since my fellowship that I do is I really try to cover everything. I don't leave raw tissue, especially in the area of airflow. Bit of gel in here.
It just reduces crusting so much and really helps healing, reduces granulation.
Yeah, exactly. Anything you can do to make the environment nice and moist. Okay.
Richard, we've just had a question. If you see the descending past artery and nerve during your medial maxillectomy, what do you do?
Don't burn it. And you know, that's all I would say. Look, I might put a little free graft over that area. So say you've got the whole thing, like the whole thing completely exposed. You can do that, right? I probably would put my free graft of my turbinate, because you've got a lovely turbinate when you do this sort of approach. And if the turbinate was involved in the pathology, well then you just take it from the other side. I'd lay a little free graft over here. Bipolar this thing, right, because that's your inferior turbinate artery. And sometimes even that can just fold over, but I'd just cover it. I wouldn't leave the nerve exposed, because you get some granulation around it. I have seen pain and things from people.
And another question, Richard, what's the antero-inferior limit of your medial maxillectomy?
The antero-inferior limit of my medial maxillectomy.
So I think, I mean, how far do you come forward?
I'd like to come this 45-degree diagonal line comes right up here into the floor. So right here. So you can see that? So right, almost just behind the piriform. And so it just gives me all of this mucosa here to drill. And you know, if you wanted a little bit more exposure here, you could continue to drill this. You could take a little bit more of Snidvong's wedge here, if you wanted to. But just for the sake of time, I've folded over. But you don't want to drill into the anterior superior alveolar canal, which will be here, coming down through here. So that's always going to, you know, right at the very front here, you're going to have that. And you're limited by where the nasolacrimal is, of course, because your sort of nasolacrimal is going up here. So as you go anterior and inferior, you're running under the nasolacrimal and Hasmus valve, and then you're limited by anterior superior alveolar. So somewhere in this zone, you have to end it. Otherwise, you've got to do a total medial maxillectomy. Cut the nasolacrimal, remove the whole thing. It's a good looking DCR. You'll get a good result from that. Okay. Now what are we doing? Lothrop?
We need to do a draft 3.
Yeah, okay. Let's do a draft 3. Let me though just. I'm gonna show you draft 3, because you don't have to do a sphenoethmoidectomy to do a draft 3, but you've got to do at least. You've got to do at least this.
So at least do the anterior joint.
Yeah, you got to do at least the dissection in front of the basal lamella. Exactly. So that's probably. I've got this little ridge here. You can see this little ridge. Yeah, there you go. And now you can see, and just once again that concept that the basal lamella it sits entirely between you and the posterior ethmoid. You've got to make a surgical opening. If you want to go from here into here and into the sphenoid, you've got to go through. Now, when I was a trainee, Simon, you know, I saw people enter it up here. It's so dangerous to do this. You've got to use the floor and you just go in down here. You know, this is where you need to be, at or below the level of the orbital floor. Okay, so let's now talk about the Lothrop. So in a Lothrop, I generally just raise these lateral flaps, exactly like we've seen here. Let me do this one here. So this one here now requires, you know, we haven't really, oh yes we have, no. Where are we? Yes, okay, so we can raise this down. Look, you can see there's a nice view how the nasolacrimal duct heads up into that area. That sump that someone said, you've got to make sure if you had a stenosis at this level and you left a little, like a little pocket here, that's what people mean by the sumping. Well, that's my interpretation of that phenomenon. Is that what you guys think?
Yep, and then it just occasionally just gushes.
And you get like a little purulent thing happening all the time. So here we are now. So you want to take an opening here that's sort of level with the front wall of the nasofrontal beak. You can use IGS to define that. That's quite helpful. Sometimes you can just mojo it on the outside. So you're going to do that. How far low I don't make big openings. I see some people still make big openings down here. I'm like, you know, normally my opening's only like a third of the way down the middle turbinate. You see that? How much? Just a small opening. And then I love this concept.
Just need to be able to drill to the other axilla across the septum.
And you've got to see it, yeah. And I come anteriorly though a fair bit to really make sure that I can actually see both sides in one view of the endoscope. Does that make sense? I don't want to be doing a Lothrop where I can't see the whole opening without seeing. So let's do this here on this side. So that's some little what we call a emissary nerve. You can't just dissect that, but that's the first olfactory neuron. Can you see that? It's really important to see that.
It's often the blood vessel that comes out with that first nerve, isn't it?
Yeah, also a little vessel, or, you know, it's been debated as to exactly what little sensory nerve, maybe a little vessel. I think it's mainly a vessel, but, you know, it could be external nasal. Someone thinks it's a branch of that. I'm not entirely sure. But then once you've seen that, you can actually then trim that off, and you can go right back to the first olfactory fascicle. Now, if you want to line up your flaps, or your window, I should say, you come now here, and with a coddle or something, come to your anterior and inferior limit, and poke through. Okay, if I can, I need a bit of tension, sorry. There you go. One, right, because my septum.
You can also do it with your 45-degree needle diathermy.
Yeah, I do it with a diathermy. But sometimes if you've got cartilage and bone there, you need to poke through with a solid instrument first if you haven't removed it. And so there's my sickle. So that I know now that that's about, see that little spot? That's about where my opening needs to come on this side. Let's get, now I've taken already a lot of the bone out here and everything else, so it's, you know, obviously you'd have thick bone to dissect onto. I think that's the first olfactory neuron there. And you know what? If you saw something here as a dissurgeon and you weren't sure whether it was the first olfactory neuron or an emissary vein, just use it as your posterior limit for now. And then it'll become obvious as you go along. It's still safe to assume that that's the spot and then find out later on that it's not. Does that make sense? I hear an outstanding...
It does make sense.
Yeah.
It's better to be too far forward than too far back.
Yeah, exactly. So same with like the corner pocket concept. That's what I love about, you know, Rod Schlosser's corner pocket concept. You know, it doesn't matter if you make a call that the corner pocket is a bit more lower than it really is, you just end up doing the dissection, and then at the end of the case you can tell that, oh, you haven't quite got it, you know. And like, so this mucosa here to me is so often thick or involved in disease that it's just not worth saving. Now, of course, we've done a bit of dissection now, so it's a little bit, you know, it's not the usual drilling style, you know, because we've already got that exposure and approach. let's put this on, and then love the 30,000 burrs, right? I mean, oh my gosh, they make the world of a modern day rhinologist so much easier. Fantastic. There's some man at Medtronic who developed that rigid ball tip that needs to be promoted. I don't know if he's ever been promoted or recognised for the great job he did at that engineering feat. So here we go here. Find my periosteum, right? So we found it already on the other side. There it is there, right? See, we've got it coming up. Now, get rid of Ritter's triangle, avoiding the sac.
Any tips for avoiding clogging the suction? Because that's the one thing about noise and hell.
Oh yeah, that'd be the one improvement in burrs, is this concept that they got to get somehow where it doesn't sit on the pole perfectly. There's some budding engineer listening to this video in the future. If you can create a non-blocking suction port for the drill, patent it. I'm sure you'll have a job with a equipment company. So there's my periosteum there, and you can see, Simon, I'm trying to do it so that I'm going to work from one side only, and I really like, you know, just having the scope down one side and the drill down the other. This is what makes it easy for me. So there's periosteum. I found periosteum on the other side.
Do you worry about the anterior periosteum?
Yeah, it's very hard to get, you know, actually, because you know it's very hard to get that angle. So you drill the anterior periosteum actually. So I would say to most people, don't worry about it. Just don't. I've seen some people start this technique, and they accidentally continue to expose the periosteum the entire way and completely remove all the bone. Like, that's not the goal. The goal is to find the periosteum so you know then where your lateral limit is, and then just work from that. You know, you can occasionally expose it here and there if you want to.
Well, I think the only time I've had a problem anteriorly, Richard, I sent you the picture of that lady that had a bone graft for a rhinoplasty.
Oh yes, and you get a little bit of a distorted anatomy to begin with. You mean?
Yeah.
Yeah, possibly. Yeah, and like, you know, you'd have to remove, like, you know, Brad Woodworth and I published an article a long time ago talking about big frontoethmoidal mucoceles and whether or not you even need to repair the anterior table, you know, and so just suction out that inner sinus cell there. So we showed that defects up to about 2 centimeters, you don't really need to do anything as long as the periosteum is intact. So if you've broken all the periosteum, then you might be in trouble. And I imagine your person with the previous recon of their nose and everything else has, you know, had a lot of broken soft tissue support already. You know, that's probably what happens there. But if the periosteum's intact, you really can get away with a lot, right? So I wouldn't worry too much about it. Now, and you know, in Australia at least, if you did get some, like say you're drilling a huge osteoma off from inside, and you did get a little bit of contour defect, well, we just use a little bit of filler. Use some Juvederm Ultra or something else is often all that's required. It's not really it's rare that you would get in. I see that occasionally after some of my malignancies, radiotherapy. You get a little bit of bone resorption. You can get some subtle changes in the bone. But you know, nothing that at the very worst a little bit of filler might not fix.
A question with Medial's triangle. Can you define it?
Say that again to me?
Medial's triangle.
Oh, Ritter's triangle. Oh yeah, sure. Sorry, yeah, good call. So I've just blasted through Ritter's triangle, but I'm not there yet, right? So there's the periosteum there. Can you see that?
Yep, that's clear.
Okay, so there's the periosteum there. There's the middle turbinate or first olfactory neuron, whatever you like to use. So the bone, this triangle, there's only a little bit of bone left to it, in front of the frontal recess, but between the periosteum and the middle turbinate. So this triangle of bone here is this block of bone that sits in front of the frontal recess. And that's what you've got to get rid of. And if you think about where you are, right, you can really go for it here, right? You don't have to worry about injuring anything because you're in front of the frontal recess, you're in front of the olfactory cleft, you're in front of the skull base. You know, as long as you stick, you know, to the fact that where your medial and lateral boundaries are, then you're absolutely fine, you know. Okay, so we're almost there right now. So you can see how we've just taken that little bit of bone. And it was interesting that this side was a lot easier than this side, right? Because this side had that thick bone sitting in front of here, right? So really, it was such a good one to start with and show. So now that I'm going to come, and I often will come side to remove the final bit. Can you see this? So I'll go into the frontal recess, Joe, and I'll put the kerrison up in here, and I'll take away the front wall. You know, David, you know, even years ago we used to still promote this, right? You know, really, because it just allows you to preserve the mucosa. And then you can see that I've got the back wall open. And I'm sorry, my view's a bit crappy. I'll try to get a wipe here. That's better, isn't it? And you can see now how we've got that whole area exposed. And you can see that there's going to be some sort of pocket here. There's that cell we saw on the screen, on the and I would absolutely get rid of all of this in real life. And I do it with a through cut like this sort of instrument like we're doing now, because it just gives you just a great ability to